In the early evening of June 24, 1998, in the quiet town of Hyde, Greater Manchester, 81-year-old Kathleen Grundy kissed her daughter Angela Woodruff goodbye after what would be their last conversation. Mrs. Grundy was in excellent health for her age, active, independent, and beloved in her community as the former mayoress of Hyde. She had an appointment the next morning, volunteer work that afternoon, and plans to visit friends over the weekend. Less than 12 hours later, Kathleen Grundy was dead. Her body was discovered by friends who came to collect her for a charity event. She was fully dressed, lying peacefully on her sofa as if she had simply fallen asleep. There were no signs of struggle, no evidence of illness, no indication that anything was amiss. Dr. Harold Shipman, her trusted family physician for years, was called to certify the death. "Old age," he told the police and the coroner's office, "perfectly natural for someone of her years." But Kathleen Grundy's death was not natural. It was murder, the final killing in a spree that would eventually reveal Dr. Harold Frederick Shipman as the most prolific serial killer in British history. Over a period of at least 23 years, this seemingly respectable family doctor had systematically murdered at least 215 of his patients, though the true number may exceed 250. He killed with injections of diamorphine, signing false death certificates, and exploiting the absolute trust his victims and their families placed in him. The story of Harold Shipman is not just the story of a serial killer. It is the story of how a pillar of the community could hide in plain sight, how systemic failures and cultural deference to medical authority allowed hundreds to die, and how one woman's refusal to accept her mother's death as natural finally exposed the truth. Harold Frederick Shipman was born on January 14, 1946, in Nottingham, England, to working-class parents Harold and Vera Shipman. He was the middle child of three, with an older sister Pauline and a younger brother Clive. By all accounts, his childhood appeared unremarkable on the surface, though beneath it lay the seeds of something far darker. Shipman's father worked as a lorry driver and later as a van driver for a pottery company. His mother Vera was a homemaker who dominated the household emotionally. Friends and family later described Vera as fiercely protective of Harold, treating him as special and apart from his siblings. She had ambitions for her middle child that far exceeded their working-class station. While she showed affection to all her children, Harold held a unique place in her heart. He was, in her eyes, destined for greatness. This favoritism shaped Harold profoundly. From an early age, he learned that he was different, better, set apart from his peers by his mother's constant reinforcement. Vera would tell neighbors and relatives that Harold would become someone important, that he would rise above their circumstances. This instilled in him both a sense of superiority and an intense need to fulfill his mother's expectations. Young Harold was a quiet, studious child. He was not particularly popular among his peers at High Pavement Grammar School. Classmates later remembered him as aloof, awkward in social situations, and uncomfortable with the rough-and-tumble dynamics of schoolyard life. He was bullied occasionally for being a teacher's pet and for his odd, superior manner. While he played rugby, a concession to fitting in, he never formed close friendships. He seemed to exist at the margins of teenage life, observing rather than participating. What Harold did excel at was academics. He was intelligent, disciplined, and competitive. He threw himself into his studies with an intensity that impressed his teachers, but further isolated him from his classmates. School became his refuge and his validation. Every good grade, every teacher's praise, reinforced what his mother had always told him. He was special, superior, destined for more than the ordinary life of Nottingham's working class. But beneath this outward success, something else was developing. Friends later recalled that Harold seemed to lack normal emotional responses. He rarely laughed genuinely. He showed little empathy when classmates experienced difficulties or tragedies. There was a coldness to him, a distance that went beyond mere shyness or awkwardness. One former classmate would later tell investigators that even as a teenager, Harold seemed to look at people as if they were specimens rather than fellow human beings. The event that would fundamentally shape Harold Shipman's psychology occurred when he was 17 years old. In 1963, his beloved mother Vera was diagnosed with terminal lung cancer. The disease progressed rapidly, and Harold witnessed her deterioration over the following months. What made the deepest impression on the young Shipman was not just his mother's dying, but the manner of her care. Vera's doctor made regular house calls to administer morphine injections for pain relief. Harold would rush home from school each day to be with his mother during these visits. He observed the ritual closely, the doctor arriving, the preparation of the injection, the administration of the drug, and then the transformation in his mother's condition. After each morphine injection, Vera would change before Harold's eyes. The pain that had contorted her face would ease. The tension would leave her body. She would become peaceful, even euphoric. For precious minutes, she would seem like herself again, the strong, loving mother who had always told him he was special. And Harold, the awkward teenage boy who struggled to connect with anyone else, would have those moments with her, moments when the pain was held at bay by the power of medicine. This experience seared itself into Harold Shipman's developing psyche in ways that would have devastating consequences decades later. He witnessed the absolute power a doctor held, the power to ease suffering, to bring peace, to control the boundary between pain and comfort, between life and death. He saw how his mother looked at her doctor with complete trust, how she surrendered to his care, how dependent she became on those injections. Vera Shipman died on June 21, 1963. Harold was devastated, but he did not grieve in any typical way. He did not cry at her funeral. He did not seek comfort from his father or siblings. Instead, he withdrew further into himself, his emotions locked away behind an even more rigid exterior. The only thing that seemed to give his life meaning was the promise he had made to his dying mother: he would become a doctor. This was no longer just about fulfilling Vera's ambitions for him. It had become Harold's entire identity. Without his mother's validation, without her constant reinforcement that he was special and superior, he needed something else to prove his worth. Medicine would be that proof. He would achieve what his mother had dreamed for him, and in doing so, he would possess the power he had witnessed in her final months, the power over life and death that doctors wielded. After his mother's death, Harold's academic performance actually improved. He passed his A-levels with strong marks and was accepted to study medicine at the University of Leeds in 1965. It was a remarkable achievement for someone from his background, and it should have been a moment of triumph. But Harold Shipman was not seeking triumph. He was seeking validation, power, and perhaps something even darker: the ability to recreate those moments from his mother's illness when he had felt most connected to her, when he had witnessed the godlike authority of a doctor to control suffering and death. At Leeds, Shipman continued the pattern established in his youth. He was academically capable but socially isolated. He had few friends and rarely participated in the social life of the university. He seemed to view his fellow students with disdain, as if they were beneath him intellectually and morally. His professors found him competent but oddly lacking in the empathy and warmth typically associated with good physicians. 1966, during his second year of medical school, Shipman met Primrose Oxtoby at a bus stop. She was 3 years younger, still in school, and came from a working-class background similar to his own. Their courtship was brief and unremarkable. Primrose was quiet, deferential, and seemed to accept Harold's sense of superiority without question. They married in November 1966, when Harold was 20 and Primrose was 17. She was 5 months pregnant. The marriage seemed to serve Harold's needs perfectly. Primrose made no demands on him emotionally. She accepted his control of the household, his decisions about their life, his superior attitude without complaint. She provided him with the appearance of normalcy, a wife, a home. Children, while allowing him to maintain the emotional distance and superiority that defined his personality. Friends would later describe their relationship as more like that of master and servant than equal partners. Harold Shipman graduated from medical school in 1970 and began his pre-registration house officer year. His performance was adequate but not exceptional. What concerned some of his supervisors was his bedside manner, or lack thereof. He seemed impatient with patients who asked questions or challenged his authority. He showed little warmth or compassion. Several senior doctors noted in his evaluations that, while Shipman was technically competent, he seemed to view patients as problems to be solved rather than people to be cared for. But these concerns were not serious enough to prevent his progression. In 1974, Harold Shipman took a position as a general practitioner at the Abraham Ormerod Medical Center in Todmorden, West Yorkshire. He was 28 years old, a qualified doctor, married with 2 young children and a third on the way. To all outward appearances, he had achieved his mother's dream for him. He was Dr. Harold Shipman, a respectable family physician in a small English town. What no one knew, what no one could have known, was that Harold Shipman had not become a doctor to heal people. The motivations that drove him were far more complex and infinitely darker. The power he had witnessed during his mother's illness, the godlike authority to control suffering and death, had become an obsession. And now, with his medical license and the trust of an entire community, he finally had the opportunity to exercise that power. The question that would haunt investigators for years was simple but devastating. When did Harold Shipman first kill? Was Kathleen Grundy really his last victim, or was she merely the last in a series that stretched back decades? How many people had already died by the time he arrived in Todmorden in 1974? The answer would prove difficult to establish with certainty. Death certificates from that era were sparse. Cremations had destroyed most of the physical evidence, and the culture of the time granted doctors almost unquestioned authority in matters of life and death. But what eventually emerged was a pattern of elderly patients dying unexpectedly, always alone, always with Dr. Shipman as the attending physician, always with death certificates signed without question. Harold Shipman, the boy who had been told he was special, the teenager who had watched his mother die, the medical student who seemed to view others with cold detachment, had found his calling. He had become what he had always been destined to be, though not in the way his mother had imagined. He had become Britain's most prolific serial killer. And for more than 2 decades, no one suspected a thing. Part 2: Early Medical Career and First Crimes. Dr. Harold Shipman arrived in Todmorden in March 1974, with every appearance of being exactly what the Abraham Ormerod Medical Center needed: a young, qualified general practitioner eager to serve a small West Yorkshire town. At 28, married with children, he seemed the model of respectable professional ambition. The senior partners who hired him saw a capable doctor with decent credentials who could help manage their growing patient list. Todmorden was a former mill town nestled in the Calder Valley, a close-knit community where everyone knew everyone, and the local GP was a figure of considerable authority and trust. For Harold Shipman, it was the perfect environment. The elderly population was substantial, the culture deferential to medical authority, and the oversight minimal. No one questioned a doctor's judgment, especially not a doctor as confident and seemingly competent as the young Dr. Shipman. From the beginning, Shipman cultivated a specific image. He was brisk and efficient, sometimes brusque, but never cruel. He seemed to work tirelessly, making house calls at all hours, responding to emergencies without complaint, taking on extra patients. He developed a reputation as a dedicated physician who would go above and beyond for his patients. The elderly women in his care particularly appreciated his attention. He would sit with them, chat about their lives, show an interest that their busy families sometimes could not. What no one realized was that this dedication masked something far darker. Harold Shipman was not working hard because he cared about his patients. He was working hard because he was feeding an addiction to the power of ending lives. The exact date of Harold Shipman's first murder may never be known with certainty. The Shipman inquiry, which would later investigate his crimes exhaustively, concluded that his killing began during his time in Todmorden between 1974 and 1975, though the lack of surviving medical records from that era made definitive proof impossible. What is certain is that, by the time suspicions first arose about Shipman in Todmorden, they had nothing to do with murder. In 1975, after less than 2 years in practice, Harold Shipman's colleagues began noticing irregularities in his prescribing patterns. A medical audit revealed that Shipman was prescribing enormous quantities of pethidine, a powerful opioid painkiller, far in excess of what would be expected for his patient load. The amounts were staggering, quantities that could not possibly be justified by legitimate medical needs. When confronted, Shipman initially denied any wrongdoing, but the evidence was overwhelming. His partners discovered he had been forging prescriptions for pethidine and administering much of it to himself. Harold Shipman, the dedicated young doctor, was a drug addict. The addiction likely began during his time at medical school or shortly thereafter. Opioids would have provided Shipman with something he desperately needed, a way to manage the emotional emptiness that defined his inner life. But more than that, the opioids connected him to his mother's final months, to those morphine injections that had brought her peace and had given him his only experience of true intimacy and power. In July 1975, Shipman was forced to resign from the Abraham Ormerod Medical Center. He was fined £600 by the local magistrate's court for obtaining drugs by deception, forging prescriptions, and unlawfully possessing pethidine. It should have ended his medical career. In many countries, it would have. But this was 1975 in Britain, and Harold Shipman was given a second chance. The General Medical Council did not strike him off the medical register. Instead, he was allowed to continue practicing after completing a drug rehabilitation program. The official explanation was that Shipman's addiction was an isolated incident brought on by the stress of a demanding practice. He had shown remorse, undergone treatment, and deserved an opportunity to rehabilitate himself professionally. What happened during those years in Todmorden before his drug addiction was discovered? This question would haunt investigators decades later. The Shipman inquiry eventually identified 3 deaths that occurred during his time there as deeply suspicious. Though without bodies to exhume or comprehensive medical records, murder could not be conclusively proven. The pattern that would later become Shipman's signature was already evident: elderly patients, usually women, dying unexpectedly while alone. In each case, Shipman was the last person to see them alive. In each case, he certified the death as natural causes without question or investigation. In each case, families accepted his medical authority without suspicion. But the inquiry suspected there were more, many more. The statistical analysis was chilling. During Shipman's time in Todmorden, the death rate among his patients was significantly higher than that of his partner's patients, particularly among elderly women. The numbers suggested that Shipman may have been killing from almost the moment he began practicing medicine. Why did he start? What psychological mechanism transformed Harold Shipman from a drug-addicted GP into a serial killer? The answer likely lies in the intersection of several factors. Shipman had always viewed himself as superior to others, special, and set apart. His mother's death had shown him the ultimate power a doctor could wield. His drug addiction gave him a chemical means of managing his emotional emptiness, while also connecting him to those memories of his mother's final months. And now, as a practicing physician with unsupervised access to vulnerable patients, he had the opportunity to exercise that power himself. Killing, for Shipman, was not about sexual gratification as it was for many serial killers. It was not about rage or revenge. It was about power and control in their purest forms. When he administered a lethal injection and watched a patient die, he was God. He controlled the exact moment of their death. He saw the life leave their eyes. He experienced the ultimate intimacy, being the last person someone saw, the last voice they heard, the final presence in their existence. And then he would sign the death certificate, face the grieving family with practiced sympathy, and accept their gratitude for all he had done for their loved one. The deception, the complete reversal of trust, only added to his sense of power. They thanked him for caring so well for their mother, their grandmother, their aunt, never knowing he had just murdered her. After his forced resignation and conviction for drug offenses, Shipman and his family left Todmorden in disgrace. But Harold Shipman was not finished. He was barely beginning. In 1977, after completing his drug rehabilitation program, Shipman took a position with the National Coal Board in County Durham, where he worked as a medical officer for 2 years. This period appears to have been relatively quiet in terms of unexplained deaths, possibly because the job involved occupational health assessments of working-age men rather than treatment of elderly patients. It was not the environment that fed Shipman's compulsions. But in September 1977, something happened that would prove significant. Shipman applied for and received reinstatement of his ability to prescribe controlled drugs. Despite his previous conviction for forging prescriptions and drug addiction, the medical authorities deemed him rehabilitated and trustworthy. It was a decision that would cost hundreds of lives. By 1977, Harold Shipman was ready to return to general practice. More importantly, he was ready to return to killing. The 2 years away from his preferred hunting ground, elderly patients in their homes, had shown him what he truly needed. It was not just the power of medical authority. It was not even the drugs, though he would continue to use them. What Harold Shipman needed was the power over life and death itself, exercised repeatedly, with complete impunity. In 1977, Shipman joined the Donnybrook Medical Center in Hyde, Greater Manchester, as a junior partner. Hyde was a market town of about 30,000 people, with a substantial elderly population. The Donnybrook practice was well established and respected, serving hundreds of patients across the area. For Harold Shipman, it was perfect. He quickly made himself invaluable to the practice. He was willing to make house calls when other doctors preferred clinic consultations. He would see patients at odd hours, visiting elderly women in their homes even late in the evening. He built a reputation as an old-fashioned GP who still cared about personal service in an age of increasing medical bureaucratization. His partners and colleagues saw him as dedicated, if sometimes difficult. Shipman had a sharp tongue and little patience for those he deemed incompetent. He could be arrogant and dismissive of other doctors' opinions, but these were viewed as minor character flaws in an otherwise excellent physician. Some even saw his brusqueness as a sign of his high standards and commitment to quality care. What no one saw, what no one could see, was that Harold Shipman's dedication was actually an obsessive need to be alone with vulnerable patients. Every house call was an opportunity. Every elderly woman who trusted him with her care was a potential victim. And the more he killed, the more skilled he became at concealing his crimes. The psychological transformation was complete. Harold Shipman was no longer simply a doctor who killed. He had become a killer who used medicine as his weapon and his cover. The oath he had taken to do no harm had been inverted into its opposite. He had found a way to combine his sense of superiority, his need for power, his addiction to control, and his medical authority into a systematic practice of murder. And he was just getting started. Between 1977 and 1992, while working at the Donnybrook Medical Center, Harold Shipman murdered approximately 71 patients. The Shipman inquiry would later identify these deaths through painstaking analysis of death certificates, cremation records, and witness testimony. But during those 15 years, no one suspected anything unusual was happening. The pattern was always the same. Shipman would visit an elderly patient at home, often for a routine matter or a minor complaint. He would be alone with them, having sent any family members out of the room on some pretext, to make tea, to fetch medical records, to give him privacy to examine the patient. He would prepare a syringe of diamorphine, often in doses far exceeding any legitimate medical purpose. He would inject the patient, usually in a vein or muscle. Within minutes, they would lose consciousness. Within 15 to 30 minutes, they would be dead. Shipman would then discover the body, call for family members, express sadness and sympathy at the sudden death, and offer to handle the death certificate to spare the family additional distress. Because he was the attending physician and could certify natural causes, no post-mortem examination was required unless family members specifically requested one. They rarely did. Why would they? Dr. Shipman had been so kind, so caring. If he said their mother had died of heart failure or a stroke, who were they to question him? The method was nearly perfect. Diamorphine, pharmaceutical heroin, was a commonly prescribed painkiller for terminal patients. Shipman's access to it was completely legitimate. In the doses he used, it would stop respiration and heart function rapidly, but would leave few traces that would appear suspicious to someone not specifically looking for it. Because most of his victims were elderly with underlying health conditions, there was always a plausible natural explanation for death. And because Shipman himself was the one certifying the deaths, there was no independent medical review. What drove him to kill with such frequency? Psychological analysis of Shipman's behavior suggests that the murders themselves had become addictive. Like many serial killers, he needed increasing stimulation to achieve the same psychological satisfaction. Where once killing might have been occasional, it became more frequent. Where once the planning and anticipation might have been enough, he needed the act itself more and more often. But Shipman was different from most serial killers in one crucial respect. He maintained absolute control. He never acted impulsively or in the grip of uncontrollable urges. Each murder was calculated, planned, and executed with medical precision. He chose his victims carefully, always vulnerable, always isolated, always trusting. He created opportunities rather than seizing them. He maintained meticulous records that appeared completely normal to outside eyes, while concealing systematic murder. This level of control, this ability to compartmentalize his life as a family man and respected doctor from his life as a serial killer, marked Shipman as a particularly dangerous type of psychopath. He felt no guilt, no remorse, no empathy for his victims. They were not people to him. They were objects, opportunities, means of feeding his need for power and control. In 1992, after 15 years at Donnybrook, Harold Shipman made a decision that would ultimately lead to his downfall, though not for many years yet. He decided to leave the group practice and open his own single-handed surgery at 21 Market Street in Hyde. The reasons he gave his partners were professional. He wanted more autonomy, more control over his practice, the ability to provide more personalized care. But the real reasons were darker. At Donnybrook, there were other doctors, receptionists, nurses, people who might notice patterns, might ask questions, might limit his access to patients. In his own practice, Shipman would have absolute authority. No one would question his decisions or his methods. He would be answerable to no one. The move to single-handed practice should have been a warning sign. But in 1992, single-handed GP practices were still common in Britain, and Shipman's decision seemed entirely reasonable. Many of his patients from Donnybrook chose to follow him to his new surgery, testimony to the trust he had built over 15 years. He quickly built up a practice of about 3,000 patients, many of them elderly. What no one realized was that Harold Shipman had just created the perfect killing ground, and the death rate was about to accelerate dramatically. Part 3. The Invisible Pattern. Harold Shipman's solo practice at 21 Market Street, Hyde, opened in January 1992. The building was a modest Victorian structure that had been converted into a medical surgery, with a waiting room, examination rooms, and a small dispensary. Shipman's wife Primrose served as practice manager, handling appointments and paperwork while maintaining the same quiet, deferential role she had always played in their marriage. To his patients, Dr. Shipman was a godsend, an old-fashioned family doctor who still made house calls, who remembered their names and their ailments, who seemed genuinely devoted to their care. He was particularly popular among elderly women, who appreciated his willingness to visit them at home when they were unwell and his apparent interest in their lives and concerns. But the move to solo practice marked a dramatic escalation in Shipman's killing. Without the constraints of partners and colleagues, without the informal oversight of a group practice, Shipman's murder rate increased exponentially. Between 1992 and his arrest in 1998, he would kill at least 144 patients, more than double the number he had killed in the previous 15 years. The acceleration revealed something crucial about Harold Shipman's psychology. The killings were not just about power or control. They had become an addiction, a compulsion that required increasing frequency to satisfy. Like a drug addict needing higher doses to achieve the same effect, Shipman needed to kill more often to feel the rush of godlike power that the murders provided. The pattern of his crimes during this period became remarkably consistent, almost ritualistic. Analysis of the deaths later revealed that Shipman killed most frequently on weekday afternoons, usually between 2 and 4 p.m. This timing was deliberate. It was after morning surgery hours but before evening appointments, giving him freedom to make house calls without rushing. It was a time when adult children would be at work, leaving elderly patients alone and vulnerable. It was a time when he was least likely to be interrupted. His victim selection also followed a clear pattern. The overwhelming majority, more than 80%, were women. Most were over 70 years old. They were typically living alone or would be alone when Shipman visited. They were often relatively healthy for their age, not terminally ill or even seriously unwell. This last detail was significant. Shipman was not helping the suffering to die. He was murdering people who might have lived for years. The method remained consistent. A house call for a minor complaint or routine check, time alone with the patient, an injection of diamorphine, and death within minutes. But Shipman's technique evolved over time. He became more brazen, more confident. Some victims were killed while seated in their living rooms, fully dressed as if they had simply fallen asleep in their chairs. Others died in their beds, positioned as if they had peacefully passed in their sleep. Shipman was staging the scenes of death, creating tableaus that suggested natural, peaceful endings. After each murder, Shipman's behavior followed a script. He would discover the body, express appropriate surprise and sadness, comfort any family members present, and offer to complete the death certificate to spare them additional burden. He would suggest cremation as the most dignified option. He would sometimes stay for a cup of tea with grieving relatives, accepting their thanks for his devoted care of their loved one, all while knowing he had just murdered the person they mourned. This aspect of Shipman's crimes, the deception of grieving families, the acceptance of their gratitude, the complete perversion of the trust they placed in him, may have been as psychologically gratifying to him as the killings themselves. He was not just powerful enough to end lives, he was clever enough to deceive everyone. The families thanked him. The community respected him. His colleagues considered him dedicated. And all the while, he was Britain's most prolific serial killer, operating with complete impunity. But cracks were beginning to appear in Shipman's facade, though it would take years for anyone to recognize them as such. Several incidents during the early 1990s should have raised alarm bells, but each was dismissed or explained away through the immense cultural deference to medical authority that characterized the era. In March 1994, Dr. Susan Booth, a fellow GP in Hyde, happened to mention to a colleague that she had noticed an unusual number of cremation forms coming from Shipman's practice. Cremation in Britain required 2 doctors to sign off on the death, the attending physician and a second, independent doctor. Dr. Booth had signed several such forms for Shipman's patients and had noticed what seemed like an unusually high death rate. The colleague suggested that Shipman simply had an older patient population. Dr. Booth accepted this explanation, despite her lingering unease. Years later, she would tell investigators that she had felt something was not quite right, but could not articulate what it was and certainly would never have imagined the truth. The suggestion that a respected GP might be murdering his patients was simply unthinkable. In 1997, another concerning pattern emerged. Monica Sparks, a local undertaker, mentioned to her colleagues that she seemed to be collecting a lot of bodies from Dr. Shipman's patients. She noted that many were found sitting up or fully dressed, which was unusual. Most people who die naturally of heart attacks or strokes are found in bed or show signs of having felt unwell. But again, the observation led nowhere. It was noted, wondered about, and then forgotten in the press of daily business. The most significant warning came in 1998, but not from medical professionals or undertakers. It came from another general practitioner in Hyde, Dr. Linda Reynolds. Dr. Reynolds had been observing a troubling pattern for some time. She had noticed that many of Shipman's patients seemed to die unexpectedly and at home. When she reviewed the death certificates Shipman had signed, she noticed he frequently listed causes of death in very broad terms: coronary thrombosis, heart failure, stroke, without the specificity typically expected. She also noticed that Shipman seemed to have far more patients dying than would be statistically expected given the age and health profile of his practice population. In March 1998, Dr. Reynolds took her concerns to John Pollard, the South Manchester coroner. She presented him with information about several deaths that seemed suspicious. She expressed worry that something untoward might be happening in Shipman's practice. It was a brave step to take. Challenging a fellow physician's competence or integrity was a serious matter that could have significant professional consequences. The coroner took Dr. Reynolds's concerns seriously enough to contact the police. Greater Manchester Police assigned the matter to Detective Inspector David Smith, who began a quiet preliminary inquiry. But the investigation was hampered from the start by the lack of concrete evidence and by the same cultural presumptions that had allowed Shipman to kill for so long. The police reviewed the death certificates and medical records Shipman had provided. They interviewed him directly, asking about his high death rate. Shipman was prepared for this. He explained that he had a particularly elderly patient population. He pointed out that he made more house calls than most modern GPs, which meant he saw patients who were frailer and closer to death. He suggested, with barely concealed condescension, that Dr. Reynolds was perhaps jealous of his superior dedication and patient rapport. The police also consulted with the local medical examiner, who reviewed a sample of Shipman's cases. The examiner found nothing overtly suspicious. The patients were elderly, they had underlying health conditions, and the causes of death listed on the certificates were all medically plausible. Without bodies to examine, most had been cremated. There was no physical evidence of foul play. In April 1998, after less than 2 months of investigation, the police closed the case. They concluded that while Shipman's death rate was higher than average, there was no evidence of criminal activity. They noted that he had an older patient population and that he provided an old-fashioned level of care that brought him into contact with patients near the end of life. The investigation was closed without Shipman ever being seriously considered as a suspect in any murders. It was a catastrophic failure of investigation, but it was also entirely predictable given the systemic and cultural factors at play. The police had no experience investigating deaths that appeared natural but were actually murders. The medical examiner, reviewing only paperwork, had no reason to suspect the certifying physician of falsifying records. The culture of the time simply did not allow for the possibility that a trusted doctor might be systematically murdering his patients. Harold Shipman had been investigated and cleared, and the killings continued. Looking back at this period, knowing what we now know, the signs seem obvious, but that is the benefit of hindsight. At the time, each individual death appeared entirely natural. Elderly people die. They die of heart attacks and strokes. They die suddenly and often at home. None of this was unusual in itself. What was unusual was the aggregate pattern, the sheer number of deaths, the consistency of circumstances, the fact that one doctor was always present. But seeing that pattern required stepping back from individual cases and looking at the statistical picture. It required someone to question not just whether any single death was suspicious, but whether the overall death rate in Shipman's practice was inexplicably high. That statistical analysis would not happen until after Shipman's arrest. But even then, even with the investigation closed and the concerns dismissed, Harold Shipman was not quite safe, because his arrogance and his need for power were about to drive him to make a mistake that would finally expose him. In the years between the police investigation and his arrest, Shipman's killing reached a fever pitch. He was murdering patients at a rate of approximately 1 every 10 days. Some weeks saw multiple deaths. His confidence was absolute. He had been investigated and cleared. The medical community trusted him. The police had found no evidence. He was, in his own mind, untouchable. But he was also becoming reckless. The murders were no longer enough by themselves. Shipman needed more power, more control, more proof of his superiority over everyone around him. He had been killing the vulnerable and taking their lives. Now he wanted to take something else, their money. This shift from pure killing to killing for profit marked a critical change in Shipman's crimes. It suggested that even the godlike power of ending lives was no longer sufficiently stimulating. He needed to demonstrate his superiority in another way, to prove that he could not only kill with impunity, but also manipulate the legal and financial systems to enrich himself. It was this escalation, this overreach born of absolute confidence and contempt for everyone around him, that would finally bring Harold Shipman down. But before that happened, he would kill again and again and again. His victims during this period included women in their 70s and 80s who should have had years of life ahead of them. They included beloved mothers, grandmothers, friends, neighbors. They were women like Winifred Meller, who at 73 was still active and healthy. Like Bianca Pomfret, who at 49 was one of Shipman's youngest victims. Like Maureen Ward, who at 57 should have had decades left. They were real people with families who loved them, with lives full of meaning and connection. And Harold Shipman erased them all, one injection at a time, with medical precision and psychopathic detachment. Their deaths were not tragedies to him. They were confirmations of his power, his superiority, his godlike control over life and death. But Shipman's God complex was about to encounter something he had not accounted for. A daughter who refused to accept her mother's death as natural, and who had the intelligence and determination to prove that it was murder. Part 4. More DATHS in plain sight. The 6 years from 1992 to 1998, during which Harold Shipman operated his solo practice, saw an explosion of deaths that, in retrospect, seem almost impossible to have gone unnoticed. The sheer scale of the killing, 144 confirmed victims during this period, with many more suspected, represents one of the most sustained murder sprees in criminal history. Yet each death was certified as natural, accepted by families, and processed through the legal and medical systems without serious scrutiny. This section examines some of the individual victims from this period, not to sensationalize their deaths, but to restore their humanity and to understand how Shipman selected, approached, and murdered them. Each victim had a name, a life, a family. Each deserved to live far longer than Harold Shipman allowed. Marie West was 81 years old when Shipman killed her on March 6, 1995. She was a widow living alone in her small terraced house in Hyde. Despite her age, Marie was remarkably independent and active. She walked to the shops daily, tended her small garden, and maintained close relationships with her children and grandchildren. On the day of her death, Marie had complained of feeling slightly unwell, nothing serious, just some minor breathlessness that concerned her enough to call Dr. Shipman. He visited her at home that afternoon. When her daughter stopped by an hour later as planned, she found her mother dead in her armchair, still fully dressed. Dr. Shipman was still there. He explained sympathetically that Marie had suffered a massive heart attack and died quickly, without suffering. He said he had tried to revive her, but it was too late. He completed the death certificate listing coronary thrombosis as the cause of death. The family, devastated but trusting in their doctor's expertise, accepted his explanation without question. What they did not know was that Marie West had been in perfect cardiac health. A medical examination just 3 months earlier had shown her heart to be strong for her age. She had no history of cardiac problems. There was no medical reason for her to have suffered a sudden, fatal heart attack. What she had suffered was a lethal injection of diamorphine administered by the doctor she trusted. Irene Turner was 67 years old, younger than many of Shipman's victims but fitting his preferred profile in every other way. She was a widow living alone, a former shop worker who had taken early retirement due to arthritis. Her daughter Carolyn visited regularly, and Irene was looking forward to becoming a great-grandmother for the first time. On July 11, 1996, Irene called Dr. Shipman's surgery complaining of feeling generally unwell. Shipman visited her at home that afternoon. When Carolyn stopped by an hour later to take her mother shopping as they had planned, she found Irene dead on her sofa. Dr. Shipman was just leaving. He told Carolyn that her mother had suffered a brain hemorrhage and died almost instantly. He said there was nothing anyone could have done. He completed the death certificate, offered his condolences, and left Carolyn alone with her grief. The autopsy that would eventually be performed on Irene Turner's exhumed body revealed no evidence of brain hemorrhage. What it did reveal was a lethal level of morphine in her system, morphine that could only have been administered shortly before her death by injection. Harold Shipman had murdered Irene Turner and then lied about the cause of her death to her daughter's face. Lizzie Adams was 77 years old when she died on February 28, 1997. She was a great-grandmother, beloved by her large extended family, known for her kindness and her remarkable memory for birthdays and anniversaries. She was in generally good health aside from some arthritis, and she was fiercely independent despite her family's suggestions that she might consider assisted living. Dr. Shipman had visited Lizzie that afternoon for what he said was a routine checkup. When her daughter arrived an hour later to help with some shopping, she found her mother dead in bed, peacefully arranged as if she had died in her sleep. Shipman was still in the house. He explained that he had just discovered Lizzie had passed away, likely from a stroke. He said it was a blessing that she had gone peacefully, without suffering. The family, though heartbroken, took comfort in the doctor's assurance that their mother had died without pain. But Lizzie Adams had not died of a stroke. She had died of morphine poisoning, administered by the man her family trusted to care for her. And Shipman's description of her peaceful death, his reassurance that she had not suffered, was a calculated lie designed to forestall any questions or investigation. One of the most tragic cases was that of Bianca Pomfret, who at 49 was one of Shipman's youngest victims. Bianca was married with children, worked part-time, and was active in her local community. She had gone to Shipman complaining of chest pain and shortness of breath, symptoms that concerned her enough to seek medical attention, but that did not suggest anything immediately life-threatening. Shipman visited her at home on December 10, 1997. He was alone with her for only about 15 minutes. When her husband returned from walking the dog, he found Bianca dead on the sofa. Shipman was just finishing examining her. He explained that she had suffered a catastrophic coronary event, what he called a massive heart attack that would have killed her within seconds. The family was devastated. Bianca was young, active, seemingly healthy. How could this have happened? But Dr. Shipman was persuasive. He explained that sometimes these things occurred without warning, that there might have been an underlying heart defect no one knew about, that nothing could have saved her. Years later, when Bianca's body was exhumed, the truth emerged. Her heart had been healthy. There was no defect, no underlying condition. What killed Bianca Pomfret was not heart disease but diamorphine administered by Harold Shipman. She should have lived another 30 or 40 years. Instead, she was murdered at 49 by a doctor who saw her not as a patient to be healed, but as an opportunity to exercise his power over life and death. Maureen Ward, 57, died on February 18, 1998, just months before Shipman's arrest. She had multiple sclerosis, which had affected her mobility but not her spirit. Despite her disability, she maintained an active social life and was devoted to her family. She had called Dr. Shipman complaining of feeling unwell, fatigue, and some pain, symptoms that her family assumed were related to her MS. Shipman visited her at home. Within an hour, Maureen was dead. Shipman told her family that her MS had caused complications that led to heart failure. Given her existing condition, the family accepted this explanation. They were grateful that Dr. Shipman had been so attentive to their wife and mother. But Maureen Ward's multiple sclerosis, while debilitating, was not immediately life-threatening. She had years of life ahead of her, years she should have spent with her family. Instead, Harold Shipman decided her time was up, administered a lethal injection, and certified her death as natural. What united all these cases, and the more than 100 others from this period, was the complete betrayal of trust. These women and their families trusted Harold Shipman with their lives and their health. They welcomed him into their homes. They believed in his medical expertise and his professional ethics, and he exploited that trust to commit murder again and again and again. The psychological mechanism that allowed Shipman to do this is worth examining. Most people struggle with cognitive dissonance when their actions contradict their stated values or professional obligations. A doctor who takes an oath to do no harm should experience profound psychological conflict when murdering patients. But Harold Shipman experienced no such conflict because he did not see his victims as people deserving of moral consideration. Psychological evaluation after his arrest suggested that Shipman had a profound narcissistic personality disorder combined with psychopathic traits. He viewed himself as superior to everyone around him, patients, fellow doctors, investigators, everyone. His patients were not people in his eyes. They were objects, opportunities, means to satisfy his need for power and control. When he sat with grieving families, accepting their thanks and their trust, he felt no guilt because he felt no empathy. Their grief was irrelevant to him. Their loss meant nothing. What mattered was that he had exercised ultimate power and gotten away with it. What mattered was that they believed him, trusted him, never suspected him. This complete lack of empathy, combined with his intelligence and his medical knowledge, made Harold Shipman one of the most dangerous serial killers in history. He was not driven by rage or sexual compulsion. He was not obviously mentally ill or out of control. He was a calculating predator who used his professional position as both weapon and shield, killing with clinical precision and deceiving everyone who might have stopped him. But Shipman's confidence was also becoming his weakness. By 1998, after more than 2 decades of killing, after hundreds of deaths, after being investigated and cleared by the police, Harold Shipman believed himself untouchable. This belief led him to become more brazen, more reckless, more daring in his crimes. He was killing more frequently, at times one victim every few days. He was taking less care to ensure his explanations were medically plausible. He was selecting victims more boldly, sometimes killing patients whose deaths would clearly invite questions. And most fatally, he was beginning to see his victims not just as opportunities to kill, but as opportunities to profit. He had murdered for power for more than 20 years. Now he was ready to add greed to his motivations. This escalation, this transition from killing for psychological gratification to killing for material gain, would prove to be Harold Shipman's downfall. Because when he decided to forge the will of Kathleen Grundy to inherit her estate, he finally made a mistake that could not be explained away, overlooked, or dismissed. He encountered a daughter who knew her mother well enough to know that something was terribly wrong. And unlike every other family who had accepted Dr. Shipman's explanations without question, Angela Woodruff had the knowledge, the resources, and the determination to prove that her mother had been murdered. The invisible pattern of death that had claimed more than 200 lives was about to become visible at last. Part 5: Growing Suspicions. By early 1998, Harold Shipman had been killing his patients for approximately 24 years. During that time, he had murdered more than 200 people, nearly all of them vulnerable elderly women who trusted him with their care. He had been investigated and cleared. He had refined his method to near perfection. He had every reason to believe he was invincible. But the warning signs that something was seriously wrong in Shipman's practice were accumulating, even if no one was yet connecting them into a coherent picture of serial murder. The 1998 police investigation triggered by Dr. Linda Reynolds had been brief and superficial, but it had rattled Harold Shipman more than he let on. For the first time in his killing career, someone had noticed the pattern. Someone had questioned his high death rate. Someone had brought concerns to the authorities. That the investigation ended without charges was both a relief and a validation for Shipman. It proved, in his mind, that he was smarter than everyone else. The police had looked at his practice and found nothing suspicious. This emboldened him rather than cautioning him. In the months following the investigation, his killing actually accelerated. But others were noticing things too, even if they were not yet piecing together the full picture. Deborah Massey was a taxi driver in Hyde who frequently transported elderly patients to and from medical appointments. In early 1998, she began noticing something odd. She seemed to be picking up a lot of elderly women from Dr. Shipman's surgery who mentioned in passing that another of his patients had recently died. Sometimes the patients she drove would mention knowing 2 or 3 people from the doctor's practice who had died in recent months. Deborah mentioned this to her husband one evening. It seemed unusual that one doctor would lose so many patients. Her husband suggested that perhaps Dr. Shipman had taken on many of the oldest patients from other practices, or that he specialized in end-of-life care. Deborah accepted this explanation but filed away the observation in the back of her mind. Years later, she would testify that she had sensed something was wrong but could not have articulated what it was. Alan Massey, no relation to Deborah, the manager of a funeral home in Hyde, had also noticed a pattern. His business handled funerals for many of Dr. Shipman's patients, and he observed that the circumstances of death often seemed similar. Elderly women, alone at home, found by Dr. Shipman or found shortly after he had visited, death certified as natural causes without post-mortem examination. What particularly struck Massey was the positioning of some bodies. Several were found fully dressed, sitting upright in chairs, as if they had simply fallen asleep. This was unusual. Most people who die naturally of cardiac events or strokes show signs of distress, are found in bed, or have some indication they felt unwell before death. The peaceful, seated death seemed almost staged. Massey mentioned his observations to colleagues at professional gatherings. Other funeral directors acknowledged they had noticed similar patterns with deaths certified by Dr. Shipman, but none of them took their concerns further. They were not medical professionals. Who were they to question a doctor's certification of death? And besides, elderly people did die. Perhaps Dr. Shipman's patients just happened to die peacefully. Dr. Susan Booth, who had signed cremation forms for several of Shipman's patients, continued to feel vague unease about the number of deaths coming from his practice. In professional conversations with other local GPs, she would sometimes mention that Shipman seemed to lose an awful lot of patients. The usual explanation offered was that he had an older patient demographic, or that he saw patients other doctors might refer to hospital care. But Dr. Booth kept noticing. In April 1998, shortly after the police closed their investigation, she signed a cremation form for another of Shipman's patients, Joan Melia, 73, who had died suddenly at home. Dr. Booth reviewed the medical history Shipman had provided and found nothing obviously suspicious, but the sheer accumulation of deaths was beginning to trouble her more seriously. She considered contacting the medical board but hesitated. What would she report? That a colleague had elderly patients who died, without concrete evidence of wrongdoing. Raising concerns might seem like professional jealousy or unfounded suspicion. The medical community was small and collegial. Accusations of incompetence or misconduct could destroy a career. Dr. Booth's unease remained just that, a feeling she could not substantiate and therefore did not act on. The person who came closest to uncovering the truth before Kathleen Grundy's death was Dr. Linda Reynolds, but even she did not imagine the full scope of what was happening. Dr. Reynolds had been concerned enough about Shipman's high death rate to contact the coroner in March 1998, triggering the police investigation. When that investigation closed with no action taken, she felt vindicated in some ways. Surely if there had been anything seriously wrong, the police would have found it. But she also felt frustrated. The death rate still seemed too high. The circumstances still seemed odd. In the months after the investigation closed, Dr. Reynolds continued to monitor the situation informally. She noted when local families mentioned losing a relative who had been one of Shipman's patients. She paid attention to death notices in the local newspaper, and the pattern continued: elderly patients, sudden deaths, Shipman as attending physician. In June 1998, Dr. Reynolds had lunch with several other local physicians. The conversation turned to the recent police investigation of Shipman. One of the doctors defended him, saying the investigation had found nothing wrong, and that questioning a colleague's competence without evidence was unprofessional. Dr. Reynolds argued that the high death rate itself was evidence that something warranted further investigation. But the other physicians disagreed. They pointed out that death rates varied between practices for many reasons: patient demographics, practice philosophy, random variation. They suggested that Dr. Reynolds might be allowing personal feelings about Shipman, who could be arrogant and dismissive, to color her professional judgment. The conversation ended tensely, and Dr. Reynolds left feeling that she was being painted as the unreasonable one. This social and professional pressure to not make waves, to not question a colleague without absolute proof, was one of the systemic factors that allowed Shipman to kill for so long. The medical profession, like many professions, had a culture of solidarity that made it very difficult to raise concerns about a peer. Add to this the general public's deference to medical authority, and you had an environment where even serious suspicions could be dismissed or explained away. Harold Shipman understood these dynamics perfectly. He knew that as long as he maintained a plausible medical explanation for each death, as long as there was no physical evidence, and as long as he could exploit the cultural reluctance to question a doctor's judgment, he was safe. But his psychological need for power and validation was pushing him toward more and more daring acts. Killing alone was no longer enough. He needed to prove his superiority in other ways. He needed to show, at least to himself, that he could manipulate not just life and death but also money, property, and the legal system. Between 1995 and 1998, Shipman made several attempts to insert himself into his patients' financial affairs. He would suggest to elderly patients that they needed to update their wills. He would recommend solicitors he knew and trusted. He would offer to witness will signings. In at least 3 cases that were later documented, Shipman attempted to manipulate patients into making him a beneficiary of their estates. In 1995, he convinced an elderly patient to make him executor of her will, though he was ultimately not named as a beneficiary. In 1996, he witnessed a will for another patient and later told the family that the patient had wanted certain items to go to him, though this was never documented. In 1997, he forged a will for a patient who died shortly thereafter, but the forgery was amateurish, and the estate was too small to attract serious attention, so the irregularities were noted but not investigated. These attempts showed that Shipman was escalating from pure killing to killing for profit, but they also showed that he was not particularly skilled at financial fraud. His forgeries were crude. His manipulations were transparent to anyone who looked carefully. What had protected him thus far was not his skill at deception, but the lack of anyone looking carefully. That was about to change. In the spring of 1998, Harold Shipman selected his next victim, Kathleen Grundy, the 81-year-old former mayoress of Hyde. She was wealthy, she was popular, she lived alone, and she trusted Dr. Shipman completely. In Shipman's mind, she was perfect, not just as a victim to kill but as a source of financial gain. What Shipman did not account for was Kathleen Grundy's daughter, Angela Woodruff. Angela was a solicitor, intelligent and thorough. She knew her mother well. She knew her mother's character, her mother's values, her mother's intentions regarding her estate. And when her mother died suddenly and a suspicious will appeared, Angela would not accept the official explanation. She would ask questions, she would investigate, and she would ultimately bring down Britain's most prolific serial killer. But before that happened, Shipman had to commit the murder that would finally expose him. And on June 24, 1998, he did exactly that. The growing suspicions that had troubled doctors, funeral directors, taxi drivers, and others for years were about to crystallize into proof. The invisible pattern was about to become undeniably visible, and Harold Shipman's quarter-century killing spree was about to end. Part 6. The Grundy Case. Kathleen Grundy was everything Harold Shipman looked for in a victim, with one critical exception. She was 81 years old but remained remarkably active and healthy. She was a widow living alone in a comfortable home. She was well off financially, with assets worth approximately £386,000. She trusted Dr. Shipman, who had been her physician for several years. And she had a daughter who lived some distance away, which meant Shipman would have time after the murder to manipulate the situation before anyone could intervene. The exception, the fatal flaw in Shipman's calculation, was the nature of that daughter. Angela Woodruff was not just any grieving child who would accept a doctor's explanation without question. She was a solicitor, trained to examine evidence critically. She had a close relationship with her mother and knew her character intimately, and she would prove to be the one person Harold Shipman could not deceive. Kathleen Grundy had served as mayoress of Hyde in the 1980s and remained active in the community. She volunteered with Age Concern, helped at the local church, and attended social clubs regularly. She was known for her kindness, her generosity, and her sharp mind. Those who knew her described a woman who was aging gracefully but showing no signs of declining health or mental capacity. On the morning of June 24, 1998, Kathleen had plans to meet friends at a senior center where she volunteered. When she failed to arrive, concerned friends went to her home at 79 Joel Lane. They found the front door locked but were able to enter through the back. Inside, they discovered Kathleen lying fully dressed on her sofa, apparently dead. Dr. Shipman was called. He arrived quickly and pronounced Kathleen dead. He told the friends who had discovered her that she had likely died of old age, perhaps with a stroke or heart failure. He said he had seen her the previous day, and she had seemed fine then, but at her age, these things happened suddenly. He offered to complete the death certificate to spare the family any additional burden during their grief. The friends, though shocked by Kathleen's sudden death, had no reason to question Dr. Shipman. He was her doctor. He had cared for her for years. If he said she had died of natural causes, who were they to doubt him? Angela Woodruff was in Warwickshire when she received the call about her mother's death. She was devastated but also confused. She had spoken to her mother by phone the evening before. Kathleen had sounded perfectly healthy, excited about her plans for the coming days. How could she have died so suddenly? Angela traveled to Hyde immediately. Dr. Shipman met with her and expressed his condolences. He explained that her mother had died peacefully, likely from a stroke or cardiac event. He said that at 81, despite her apparent good health. These sudden deaths were not uncommon. He had already completed the death certificate listing old age as the cause of death, a vague but legally acceptable certification for someone over 70. Something about the explanation troubled Angela, but in her grief she could not articulate what it was. Her mother had seemed so healthy, so full of life. But Dr. Shipman was convincing, sympathetic, and authoritative. Angela accepted what he told her, though a nagging doubt remained in the back of her mind. Then, on June 26, 2 days after her mother's death, Angela received a phone call that transformed her grief into suspicion. A solicitor from a firm she had never heard of contacted her to discuss her mother's will. Angela was confused. She was her mother's solicitor and had drafted her will years earlier. Why would her mother have used a different firm? The solicitor explained that Mrs. Grundy had apparently made a new will just months earlier, in February 1998. This new will left her entire estate, nearly £400,000, to Dr. Harold Shipman. Angela was stunned. This made no sense. Her mother had very clear intentions for her estate, which she had discussed with Angela many times. She wanted to leave her money to her daughter and to several charities she supported. She had mentioned Dr. Shipman occasionally as a good doctor, but she had never indicated any special regard for him and certainly had never mentioned wanting to leave him anything in her will. Moreover, the timing was suspicious. Why would an 81-year-old woman suddenly change her will to benefit her doctor just 4 months before dying? And why would she do so without telling her daughter, who was also her solicitor? Angela requested a copy of the will. When it arrived, her suspicions deepened into certainty that something was terribly wrong. The will was typed on a manual typewriter, full of spelling errors and grammatical mistakes. The signature purporting to be her mother's looked wrong. The handwriting was similar but not quite right, and the signature lacked the firmness and confidence of her mother's usual signature. The witnesses were listed as 2 of Dr. Shipman's patients, neither of whom her mother knew well. Angela Grundy was now faced with a choice. She could accept the will, accept her mother's death as natural, and move on with her grief. Or she could follow her instincts, which were screaming that something was fraudulent about this will and possibly about her mother's death. On June 30, less than a week after her mother's death, Angela contacted the police. She told them she believed the will was forged and that her mother's death might be suspicious. It was an extraordinary allegation to make. She was essentially suggesting that a respected local doctor had murdered her mother and forged a will to steal her money. The police took Angela's complaint seriously enough to begin an investigation. Detective Inspector Stan Edgerton was assigned to the case. He started by examining the will that had so troubled Angela. His initial assessment was that her concerns had merit. The will looked amateurish. The typing was poor, and the circumstances were indeed suspicious. Edgerton contacted the witnesses named in the will. They were Paul Spencer and Claire Hutchinson, both patients of Dr. Shipman. When interviewed, both confirmed they had signed the document, but their accounts were troubling. Spencer said Dr. Shipman had asked him to sign something without really explaining what it was. Hutchinson said the same. Neither had read the document. Neither had seen Mrs. Grundy sign it. Both had simply done what their trusted doctor asked without question. This was highly irregular. Witnesses to a will are supposed to see the testator sign the document and confirm that the testator is signing of their own free will and understands what they are signing. Spencer and Hutchinson had done neither. They had simply signed when asked by Dr. Shipman. Edgerton's next step was to have the will examined by a handwriting expert. The expert's conclusion was unequivocal. The signature purporting to be Kathleen Grundy's was a forgery, and a rather poor one. The person who had forged it had tried to copy her signature from another document but lacked the skill to replicate the subtle characteristics of her genuine handwriting. The investigation was now focusing on Dr. Shipman as a suspect in forgery and possibly fraud. But Angela Woodruff pushed for more. If Shipman had forged the will, she argued, then her mother's death itself was suspect. She formally requested that her mother's body be exhumed for post-mortem examination. This was an extraordinary request, but given the evidence of forgery, the coroner agreed. On August 1, 1998, just over 5 weeks after her death, Kathleen Grundy's body was exhumed from her grave in Hyde Cemetery. The post-mortem examination was conducted by Dr. John Rutherford, a home office pathologist. What he found would change the entire investigation from suspected fraud to murder. Tissue samples taken from Kathleen's body showed lethal levels of morphine, specifically diamorphine, pharmaceutical heroin. The concentration was so high that it could only have been administered by injection shortly before death. There was no medical reason for Kathleen Grundy to have been injected with diamorphine. She was not in pain. She was not dying of cancer. She had no condition that would require such powerful pain medication. The only explanation for the presence of lethal amounts of morphine in her system was that someone had murdered her. And the only person who had been alone with her shortly before her death, the only person who had access to diamorphine, the only person who had anything to gain from her death, was Dr. Harold Shipman. On September 7, 1998, police arrested Harold Shipman at his surgery on Market Street. He was charged with the murder of Kathleen Grundy, the forgery of her will, and 3 counts of obtaining property by deception. He was taken to Ashton-under-Lyne Police Station for questioning. Shipman's reaction to his arrest was telling. He showed no fear, no remorse, no surprise. Instead, he seemed almost indignant that anyone would dare to question him. He denied murdering Mrs. Grundy. He claimed he knew nothing about any forged will. He suggested that Mrs. Grundy must have been a drug addict who had administered the morphine to herself, a claim so absurd that it revealed Shipman's contempt for the investigator's intelligence. During his police interviews, Shipman maintained his innocence, but offered no coherent alternative explanation for the evidence against him. He could not explain how Kathleen Grundy, who had no history of drug use, had obtained lethal quantities of diamorphine. He could not explain why she would have injected herself. He could not explain the forged will. He simply denied everything and expressed outrage that he was being suspected of such terrible crimes. But while Shipman sat in custody maintaining his innocence, the investigation was expanding exponentially. Because once detectives began looking at other deaths Shipman had certified, a horrifying pattern emerged. Dr. Reynolds's earlier concerns were revisited. Funeral directors' observations were documented. Death certificates were pulled and analyzed. And as investigators dug deeper, they began to realize that Kathleen Grundy was not an isolated case. She was the tip of an iceberg, the final victim in a killing spree that had lasted more than 2 decades. On October 5, 1998, police obtained permission to exhume the bodies of several other women who had died under Shipman's care. The first was Winifred Meller, 73, who had died in May 1998. Her body showed lethal levels of morphine. Then Bianca Pomfret, 49, who had died in December 1997, more morphine. Then Joan Melia, 73, who had died in June 1998, again morphine. Each exhumation confirmed the same pattern. Each woman had been killed by an injection of diamorphine. Each had died alone with Dr. Shipman. Each had been certified as dying of natural causes when they had actually been murdered. By November 1998, Shipman had been charged with 15 counts of murder. The investigation was still ongoing, with more bodies being exhumed and more cases being examined. But the scope of what was emerging was almost beyond comprehension. The respected family doctor, the pillar of the community, the man who had been trusted with the lives and health of thousands of patients, was a serial killer on a scale Britain had never seen. Angela Woodruff's refusal to accept her mother's death as natural, her determination to pursue the truth despite the personal cost, had exposed one of the most prolific serial killers in history. If she had accepted Dr. Shipman's explanation, if she had not questioned the suspicious will, Harold Shipman might have continued killing for years more. Instead, he was in custody, facing trial for multiple murders. And the full horror of what he had done was only beginning to emerge. Part 7. The Investigation begins. The arrest of Harold Shipman in September 1998 triggered one of the largest and most complex murder investigations in British criminal history. As detectives began examining the deaths of patients in Shipman's care, they confronted a scale of killing that seemed almost impossible to comprehend. This was not a case of a few suspicious deaths. The evidence suggested systematic murder spanning more than 2 decades, with victim counts that would ultimately exceed 200. Detective Inspector Stan Edgerton, who had begun the investigation into Kathleen Grundy's death, was now heading an inquiry that was growing exponentially by the day. The initial focus was on confirming additional murders through exhumation and toxicological analysis, but investigators quickly realized they faced unprecedented challenges. The first challenge was the sheer number of potential victims. Shipman had been practicing medicine for 24 years, during which time hundreds of his patients had died. Which deaths were natural and which were murders? Without examining every body, how could they know? The second challenge was the destruction of evidence. Shipman had consistently recommended cremation to grieving families, often helping them make the arrangements. Cremation destroys the physical evidence that toxicological analysis requires. Of the estimated 250 or more patients Shipman murdered, approximately 80% had been cremated. Their bodies could not be exhumed, their tissues could not be tested, and conclusive proof of murder was therefore impossible. The third challenge was Shipman's own medical records. As the certifying physician, Shipman had complete control over the documentation of his patients' final illnesses and deaths. He had systematically falsified medical records to support the causes of death listed on death certificates. Investigators would later discover that in many cases, Shipman had altered computer records after a patient's death to create a false medical history that justified the death certification. Despite these obstacles, the investigation proceeded methodically. The decision was made to focus initially on cases where bodies could be exhumed and toxicological evidence obtained. This would provide the strongest proof for prosecution, while also establishing the pattern that could support other murder charges where physical evidence was unavailable. Between October 1998 and March 1999, police exhumed 12 bodies of women who had died under Shipman's care. The toxicological results were consistent and damning. Each body showed lethal levels of morphine or diamorphine. Each woman had died suddenly and unexpectedly while alone with Dr. Shipman. Each had been certified as dying of natural causes when they had actually been poisoned. The victims whose bodies were exhumed represented a cross-section of Shipman's typical prey. Winifred Meller, 73, had died May 11, 1998. She was found dead in her home shortly after Shipman visited. He certified coronary thrombosis as the cause of death. The post-mortem revealed morphine poisoning. Bianca Pomfret, 49, died December 10, 1997. Shipman claimed she had suffered a massive heart attack. Exhumation showed lethal morphine levels and a healthy heart. Joan Melia, 73, died June 12, 1998. Shipman certified heart disease. Morphine poisoning was the actual cause. Ivy Lomas, 63, died May 29, 1997. Uniquely, she had died at Shipman's surgery rather than at home. Shipman claimed heart failure. The exhumation revealed morphine poisoning. Marie Quinn, 67, died November 24, 1998, after Shipman's arrest but before he was charged with her murder. The examination showed morphine poisoning. Each exhumation confirmed the pattern and strengthened the case against Shipman. But investigators wanted more than just proof that these women had been murdered. They wanted to understand the full scope of Shipman's crimes and to identify as many victims as possible, even those whose bodies had been cremated. This led to the second phase of the investigation: statistical analysis of all deaths certified by Shipman throughout his career. Detective Superintendent Bernard Postles led this effort, coordinating with medical statisticians, forensic accountants, and computer specialists. The analysis was painstaking. Investigators obtained death certificates for every patient who had died under Shipman's care from 1974 through 1998. They compared his death rate to those of other GPs in similar practices. They analyzed the timing, location, and circumstances of deaths. They examined patterns in the causes of death Shipman certified. What emerged was statistical evidence of mass murder. Shipman's death rate was wildly inconsistent with his colleagues. During his years in solo practice, his elderly female patients died at a rate approximately 3 times higher than would be expected. The deaths clustered around specific times. Weekday afternoons between 2 and 4 p.m., the victims were disproportionately women living alone. The causes of death Shipman certified were often vague: coronary thrombosis, heart failure, stroke, terms broad enough to be plausible but generic enough to avoid detailed scrutiny. Most damningly, there was a spike in deaths immediately following the 1998 police investigation that had been closed without charges. In the 4 months between the investigation being closed in April and Shipman's arrest in September, he had killed at least 12 patients, an acceleration that suggested he felt emboldened by having been investigated and cleared. While the statistical analysis proceeded, investigators were also examining Shipman's medical records with the help of computer forensic specialists. What they discovered was systematic falsification on a massive scale. Shipman used a medical software system called Microdoc to maintain patient records. The system automatically recorded when entries were made or modified. Forensic analysis revealed that Shipman had routinely altered patient records after their deaths to create false medical histories that supported his death certifications. For example, if he killed a patient and certified heart disease as the cause of death, he would then go back into that patient's electronic records and add entries dated weeks or months earlier, noting chest pain, shortness of breath, or other cardiac symptoms. These false entries would appear to show a pattern of declining heart health that made the sudden death seem plausible. The computer system's timestamp metadata exposed these falsifications. Investigators could prove that entries purporting to be from months before a patient's death had actually been created hours or days after the death. This evidence was crucial because it showed premeditation and consciousness of guilt. Shipman knew he was murdering patients and was deliberately creating false documentation to cover his crimes. By early 1999, the investigation had expanded to examine Shipman's entire career. Investigators traveled to Todmorden to review deaths during his time there. They identified at least 3 suspicious deaths from that period, though the lack of medical records and the cremation of the bodies made definitive proof impossible. They also discovered Shipman's 1975 conviction for forging prescriptions and drug addiction. This revelation was shocking to many in Hyde who had known Shipman for years. He had never mentioned his past conviction, and it had not been widely known in the community. The knowledge that he had a history of dishonesty and had been given a second chance that he had so grotesquely abused added another layer of tragedy to the case. As the investigation progressed, families of deceased patients began coming forward with their own suspicions and concerns. Some had felt at the time that their loved one's death was unexpected or inadequately explained. Others had noticed small inconsistencies: a mother who had been healthy suddenly dying, a death certificate that did not quite match what the family knew of the deceased's health, an oddly insistent recommendation from Dr. Shipman that the body be cremated quickly. Each family's story added pieces to the emerging picture, but each story also represented unimaginable pain: the realization that a loved one had been murdered, that the grief they had carried for years was compounded by betrayal, that the doctor they had trusted had killed someone they loved. The investigation also revealed several near misses, occasions when Shipman's crimes had almost been discovered but were not. In 1985, a colleague had questioned Shipman about a patient death and been satisfied with his explanation. In 1994, an undertaker had noted to the coroner that she had collected an unusual number of bodies from Shipman's practice. The coroner had acknowledged the observation but taken no action. In 1997, a pharmacist had questioned the quantity of diamorphine Shipman was ordering. Shipman had explained that he was treating several terminal patients, and the pharmacist had accepted this. Each near miss represented an opportunity to stop Shipman that had been missed. Each might have saved dozens of lives if it had been pursued. The weight of these missed opportunities would later become a central focus of the public inquiry into the case. By June 1999, less than a year after Kathleen Grundy's death, prosecutors had enough evidence to proceed to trial. Shipman was charged with 15 counts of murder, the maximum that could be practically tried in a single case. These were the cases with the strongest evidence: exhumations showing morphine poisoning, computer evidence showing falsified records, witness testimony establishing opportunity and behavior consistent with murder. The 15 victims for which Shipman would stand trial were Kathleen Grundy, 81; Winifred Meller, 73; Joan Melia, 73; Bianca Pomfret, 49; Ivy Lomas, 63; Marie West, 81; Lizzie Adams, 77; Jean Lilly, 58; Irene Turner, 67; Maureen Ward, 57; Marie Quinn, 67; Kathleen Wagstaff, 81; Nora Nuttall, 65; Pamela Hillier, 68; Muriel Grimshaw, 76. These 15 women represented only a fraction of Shipman's victims, less than 10% of the eventual confirmed death toll. But they provided the evidentiary foundation for what would be one of the most significant criminal trials in British history. As preparations for trial began, the investigation continued. More deaths were being examined. More families were coming forward. More evidence of systematic murder was accumulating. The full horror of what Harold Shipman had done was still emerging, but already it was clear that Britain was confronting its most prolific serial killer, a trusted doctor who had spent more than 2 decades murdering the patients who trusted him most. Part 8: Arrest and Discovery. Harold Shipman's arrest on September 7, 1998, marked the beginning of his transformation from respected doctor to exposed killer, though he would never admit to his crimes. The man who had spent 24 years presenting himself as a dedicated physician, who had looked grieving families in the eye after murdering their loved ones, who had signed hundreds of false death certificates without hesitation, now faced the dismantling of his carefully constructed facade. The arrest took place at Shipman's surgery at 21 Market Street, Hyde. Detective Inspector Stan Edgerton arrived with several officers mid-morning, when Shipman was between patient appointments. They informed him he was under arrest for the murder of Kathleen Grundy, the forgery of her will, and related fraud offenses. Shipman's reaction was reported by officers as one of controlled indignation rather than fear or shock. He did not protest his innocence dramatically. He did not ask what evidence they had. Instead, he calmly asked if he could inform his wife and collect some personal items. The detachment, the lack of normal emotional response to being arrested for murder, was the first glimpse investigators had of the personality beneath Shipman's professional exterior. Primrose Shipman was at the surgery, serving as practice manager as she had throughout their marriage. Her reaction to her husband's arrest was one of apparent disbelief and distress. She maintained then, and would maintain throughout the investigation and trial, that her husband was innocent and that the charges were a terrible mistake. Whether Primrose genuinely believed in her husband's innocence or was deeply in denial has remained a subject of speculation, but she never wavered in her public support of him. At Ashton-under-Lyne Police Station, Shipman was processed and placed in a cell. He was given the opportunity to contact a solicitor, which he did. Then began the first of many police interviews that would take place over the coming months. The initial interviews focused on Kathleen Grundy's death and the forged will. Shipman denied everything. He claimed he had last seen Mrs. Grundy alive the day before her death and that she had seemed in good health. He denied having any knowledge of a will leaving her estate to him. He suggested that if such a will existed, someone else must have forged it, perhaps someone trying to frame him. When confronted with the evidence of morphine poisoning, Shipman's explanation was both absurd and revealing. He suggested that Kathleen Grundy must have been a secret drug addict who had somehow obtained morphine and administered it to herself. When investigators pointed out that this made no sense, there was no evidence of drug use, no source for the morphine, no reason for her to kill herself, Shipman simply shrugged and said that clearly something unusual must have happened because he certainly had not killed her. This pattern would repeat throughout the interviews. When faced with evidence, Shipman would offer implausible alternative explanations or simply deny knowledge. He never became emotional, never showed guilt or remorse, never expressed sympathy for the victims or their families. His primary emotion seemed to be annoyance that he was being questioned at all. The detachment and the bizarre alternative explanations gave investigators their first real insight into Shipman's psychology. This was not a man who had killed in passion or rage. This was not someone consumed by guilt. This was a man who genuinely seemed to believe he was above reproach, that his word should be accepted without question, that the evidence against him was somehow less important than his status as a doctor. As the investigation expanded and more bodies were exhumed, Shipman was re-interviewed about each new murder charge. His responses followed the same pattern. He would deny the murder. He would offer some alternative explanation. The patient was older than their years. They had hidden health problems. They must have taken drugs without his knowledge. He would express frustration that the investigators did not believe him, as if his professional status as a doctor should make his word unquestionable. During one interview about Bianca Pomfret's death, Shipman claimed she had died of a heart attack. When presented with evidence that her heart was healthy and she had been poisoned with morphine, he suggested she must have obtained morphine from another source. When asked what possible source a 49-year-old housewife would have for pharmaceutical morphine, he said he could not explain it, but insisted he had not given it to her. The interviews revealed not just Shipman's guilt, but his profound contempt for everyone around him. He seemed to view the investigators as less intelligent than him, the evidence as somehow flawed, the entire process as a waste of his valuable time. He never asked about the families of his victims. He never expressed concern for his patients' welfare after his arrest. His focus was entirely on himself and his indignation at being suspected. While Shipman sat in custody maintaining his innocence, the police investigation was uncovering evidence that went far beyond the murder charges. Detectives searching Shipman's home and surgery discovered records that suggested financial manipulation of multiple patients. In his home office, investigators found jewelry, small valuables, and personal items that had belonged to deceased patients. Some families later identified items that had gone missing after their relatives' deaths: a ring, a brooch, a fountain pen. Shipman had been taking trophies from some of his victims, keeping physical reminders of his murders. More disturbing were records suggesting Shipman had attempted to manipulate or steal from other patients beyond Kathleen Grundy. Investigators found draft wills in Shipman's handwriting for several deceased patients, documents that had never been filed or formalized. They found records of patients who had made him executor of their estates. They found evidence of small thefts, medications, valuables from patients' homes. This evidence painted a picture of escalation. Shipman had started as a killer who murdered for psychological gratification. Over time, he had become a killer who also exploited his victims financially. The forged will for Kathleen Grundy was not an isolated incident, but part of a broader pattern of theft and fraud that had accompanied the murders. The computer forensic analysis of Shipman's patient records provided some of the most damning evidence. Specialists were able to demonstrate conclusively that Shipman had altered medical records after patients' deaths to create false medical histories. The pattern was consistent. Shipman would kill a patient, certify death from some natural cause, and then go back into the computer system and add medical notes dated before the death that supported his certification. If he certified heart disease, he would add notes about chest pain and shortness of breath. If he certified stroke, he would add notes about headaches and confusion. But the computer's metadata betrayed him. Every entry in the system was automatically time-stamped. When investigators examined the files, they could see that these historical notes had actually been created hours or days after the patient's deaths. Shipman had thought he was creating a convincing medical record. Instead, he had created electronic evidence of premeditation and consciousness of guilt. In one particularly revealing case, Shipman had killed a patient and certified coronary heart disease. He then went into the computer and created a series of backdated notes describing cardiac symptoms. But the metadata showed all these notes had been created in a single session, just hours after the death, with each entry created seconds apart. There was no way these could be genuine contemporaneous medical notes. They were obviously fabricated in bulk to support a false death certificate. This evidence was devastating to any claim that Shipman was simply a doctor who had made honest mistakes or whose elderly patients had coincidentally died in his care. The falsified records proved he knew he was killing people, knew his death certifications were fraudulent, and was deliberately creating false documentation to conceal his crimes. As the evidence mounted, the Crown Prosecution Service began building the case for trial. The decision was made to charge Shipman with 15 murders, cases where the evidence was strongest, and the prosecution could prove murder beyond reasonable doubt. These would primarily be cases where bodies had been exhumed and morphine poisoning proven, supplemented by the computer evidence and witness testimony. But everyone involved in the investigation knew that 15 murders represented only a fraction of Shipman's victims. The statistical analysis suggested he had killed more than 200 patients. The patterns were clear, the evidence compelling. But without bodies to exhume, without physical proof of poisoning, many of these deaths could not be prosecuted in criminal court. This reality was agonizing for the families of suspected victims. Many came forward believing their loved ones had been murdered, certain that the circumstances of death matched Shipman's pattern. But if the body had been cremated, if the computer records showed no suspicious alterations, if there were no witnesses to the final moments, then a criminal prosecution was impossible. The decision was made that after the criminal trial, there would need to be a public inquiry to examine all of Shipman's suspected victims, to provide families with answers even where criminal prosecution was impossible, and to identify the systemic failures that had allowed him to kill for so long. By Christmas 1998, Harold Shipman, Part 9, The Trial. The trial of Harold Frederick Shipman began on October 5, 1999, at Preston Crown Court in Lancashire. The venue had been moved from Manchester to ensure a fair trial, given the extensive publicity the case had received in Greater Manchester. The Honourable Mr. Justice Forbes presided over what would become one of the most significant murder trials in British legal history. Shipman was charged with 15 counts of murder and 1 count of forgery relating to Kathleen Grundy's will. The prosecution was led by Richard Henriques QC, who faced the formidable task of proving that a respected doctor had systematically murdered his patients. The defense was led by Nicola Davies QC, who would argue that the deaths were natural and the evidence circumstantial. From the opening day, the courtroom was packed with media, families of victims, and members of the public desperate to understand how a trusted physician could become a mass murderer. Shipman sat in the dock appearing calm and composed, showing no visible emotion as the charges were read. Richard Henriques opened the prosecution's case with a statement that would set the tone for the entire trial. Harold Shipman betrayed the trust of his patients in the most fundamental way. He was a doctor who killed, not in passion or in anger, but systematically, repeatedly, and with calculation. The prosecution's strategy was methodical. Rather than overwhelm the jury with the suspected 200-plus victims, they focused on the 15 cases where evidence was strongest. For each victim, they would establish the same pattern: a healthy or stable patient, a visit from Dr. Shipman, sudden death, a falsified medical record, and physical evidence of morphine poisoning. The first victim discussed was Kathleen Grundy, as her case had triggered the investigation. Angela Woodruff testified about her mother's health, her character, her estate plans, and her complete shock at the forged will. Her testimony was powerful and emotional, establishing not just the facts of the case but the human cost of Shipman's crimes. "My mother was a vibrant, healthy woman," Angela told the court. "She had plans, she had energy, she had so much life left to live. The suggestion that she died of old age is absurd, and the idea that she would leave her entire estate to her doctor, a man she barely knew outside of medical appointments, is beyond belief." The prosecution then presented the forensic evidence. The exhumation results showing lethal levels of morphine, the handwriting analysis proving the will was forged, and witness testimony from the 2 patients Shipman had pressured into signing the document without reading it. For each of the 15 victims, the prosecution followed the same pattern. They called family members to testify about their loved one's health and the circumstances of death. They presented the exhumation and toxicology results showing morphine poisoning. They introduced computer evidence showing Shipman had falsified medical records after death. They demonstrated that in each case, Shipman had been the last person to see the victim alive, had certified natural death, and had created false documentation to support his certification. The computer forensic evidence was particularly damning. Expert witnesses explained how Shipman's medical software worked, how it timestamped every entry, and how analysis of these timestamps revealed systematic falsification. The jury saw demonstrations of how Shipman would create backdated entries in a single session, sometimes entering weeks of fake medical notes within minutes. One expert testified, "What we see is not a doctor maintaining contemporaneous records. We see someone creating false historical records to justify death certifications they knew to be fraudulent. The pattern is unmistakable and appears in case after case." The prosecution also presented statistical evidence showing Shipman's death rate was dramatically higher than his peers. Medical statisticians testified that the probability of so many patients dying in Shipman's care, under such similar circumstances, by chance alone was essentially zero. Something was causing these deaths beyond natural causes. Perhaps most powerful were the testimonies of family members. Witness after witness described loved ones who had been healthy, who had died unexpectedly, who had been certified by Dr. Shipman as having conditions they had never been diagnosed with. They described Shipman's behavior after the deaths, his sympathy that seemed slightly off, his insistence on cremation, his offers to complete paperwork to spare the family burden. One daughter testified, "He looked me in the eye and told me my mother had died of heart disease. He was so calm, so professional. I believed him because why would I not? He was her doctor. Now I know he had just murdered her and was lying to my face." The cumulative effect of this testimony was overwhelming. The jury was not hearing about abstract victims or statistics. They were hearing about real women, mothers, grandmothers, friends, who had trusted their doctor and been murdered by him. They were seeing the grief and betrayal of families who had spent years believing their loved ones died naturally, only to discover they had been killed. The defense strategy, as it emerged, was to challenge the evidence while avoiding directly accusing investigators of fabrication. Nicola Davies QC argued that the toxicological evidence could be unreliable, that morphine could have been administered by someone other than Shipman, that the computer evidence showed only that records were updated, which doctors routinely do, and that the high death rate could be explained by Shipman having an older, sicker patient population. But this strategy faced significant challenges. The defense could not explain how elderly women with no history of drug use had obtained pharmaceutical morphine. They could not explain why Shipman's computer records showed patterns of bulk backdating that were inconsistent with normal medical practice. They could not explain the forged will or the jewelry from deceased patients found in Shipman's home. Shipman himself chose not to testify in his own defense, a decision that removed any opportunity for him to explain his actions, but also protected him from cross-examination. His silence meant the jury never heard him claim innocence directly, never saw him under the pressure of hostile questioning, but also never had the chance to judge his credibility as a witness. The prosecution called over 100 witnesses during the trial. Each piece of evidence, each testimony, added to the overwhelming picture of systematic murder. Families of the 15 victims sat in the gallery day after day, hearing the details of how their loved ones had died, seeing the evidence that the doctor they had trusted had murdered them. In late January 2000, after 57 days of testimony, both sides rested their cases. Richard Henriques delivered a powerful closing argument telling the jury, "You have heard evidence of a doctor who had become death itself. He selected his victims, he administered poison, he watched them die, and he deceived their families. The evidence is clear, consistent, and overwhelming. Harold Shipman is a murderer on a scale this country has never seen." Nicola Davies, in her closing for the defense, argued that the prosecution had not proven their case beyond reasonable doubt, that coincidence and circumstance did not equal murder, and that the jury should not convict based on statistics and suspicion. But her arguments seemed to carry little weight against the mountain of evidence the prosecution had presented. Mr. Justice Forbes gave his summing up to the jury, carefully explaining the law on murder, the burden of proof, and the need to consider each count separately. He instructed them that they must be sure of guilt beyond reasonable doubt, but he also noted that the similar fact evidence, the pattern across all 15 cases, was relevant to their deliberations. On January 31, 2000, the jury retired to consider their verdict. The wait was agonizing for the families who had sat through the trial. They had heard the evidence, seen the proof, but now 12 strangers would decide whether Harold Shipman would be held accountable for murdering their loved ones. The jury deliberated for 6 days. On the afternoon of January 31, 2000, they returned to court with their verdicts. The courtroom was silent as the foreman stood to deliver the findings. Guilty of the murder of Kathleen Grundy. Guilty of the murder of Winifred Meller. Guilty of the murder of Joan Melia. One by one, the verdicts were read. 15 counts of murder, 15 guilty verdicts. 1 count of forgery, guilty. Harold Shipman stood in the dock showing no emotion as each verdict was announced. He did not react, did not move, gave no sign that he had heard or cared about the jury's findings. His face was blank, his posture rigid. Even in this moment of absolute condemnation, he gave nothing away. Mr. Justice Forbes addressed Shipman directly before sentencing. "You have finally been brought to justice for the wicked crimes you have committed. You murdered each and every one of your victims by a calculated and cold-blooded perversion of your medical skills. You took advantage of and grossly abused their trust. You were, after all, each victim's doctor." The judge then imposed 15 concurrent sentences of life imprisonment and recommended that Shipman never be released. "In your case, I consider the sentence of life imprisonment is not sufficient," he said. "I recommend you spend the remainder of your days in prison." As Shipman was led from the dock to begin his life sentence, families of victims wept, some in relief that justice had been done, others in grief for loved ones whose murders had been proven but whose loss could never be remedied. Harold Shipman had been convicted of 15 murders, but everyone in that courtroom knew the true death toll was far, far higher. The trial had answered the question of Shipman's guilt beyond doubt, but it had raised many more questions. How many had he really killed? How had he gotten away with it for so long? What systemic failures had allowed Britain's most prolific serial killer to operate for more than 2 decades? And what could be done to ensure nothing like this ever happened again? These questions would be addressed in the public inquiry that would follow. But for now, Harold Shipman was behind bars, a convicted murderer who would never practice medicine again, never kill again, never walk free again. The doctor who had become death had finally been stopped. Part 10. The Shipman Inquiry. The conviction of Harold Shipman in January 2000 answered one question definitively. He had murdered at least 15 of his patients, but it raised far more questions than it resolved. How many people had Shipman really killed? How had he evaded detection for so long? What systemic failures in medicine, law enforcement, and regulatory oversight had allowed a doctor to commit mass murder for more than 2 decades? To address these questions, the British government established the Shipman Inquiry under the chairmanship of Dame Janet Smith, a High Court judge. Announced in January 2001, the inquiry's mandate was comprehensive: determine who Shipman had killed, when, and how, examine how he had avoided detection, and recommend changes to prevent similar crimes in the future. The inquiry would ultimately produce 6 reports totaling more than 2,000 pages, published between 2002 and 2005. It would examine more than 500 deaths, interview over 1,000 witnesses, and produce findings that shocked even those familiar with the case. The inquiry's work would confirm Harold Shipman as the most prolific serial killer in modern history. The first report, published in July 2002, addressed the central question: who did Shipman kill? Dame Janet and her team undertook a systematic review of every death that occurred in Shipman's care from the beginning of his medical career in 1970 through his arrest in 1998. The methodology was rigorous. For each death, the inquiry examined medical records, death certificates, witness testimony from family and friends, and any physical evidence available. They looked at the pattern of each death, timing, circumstances, Shipman's behavior, the death certification, disposal of the body. They compared Shipman's death rates to statistical norms for similar practices. The findings were horrifying. The inquiry concluded that Harold Shipman murdered at least 215 patients, and possibly as many as 260. The true number would never be known with certainty because of cremations, missing records, and the passage of time, but the confirmed death toll made Shipman the most prolific serial killer in British history, and one of the most prolific in world history. The 215 confirmed victims spanned the entire length of Shipman's career. 3 victims during his time in Todmorden, 1970-41975. Approximately 71 victims while at the Donnybrook Medical Center, 1977-1992. At least 143 victims during his solo practice, 1990-1998. The demographics of the victims revealed Shipman's clear preference. 171 of the 215 confirmed victims, nearly 80%, were women. The average age was 77. Most were living alone or would be alone when Shipman visited. Nearly all died between 1 p.m. and 6 p.m. on weekdays. The first report also identified the method in detail. Shipman killed almost exclusively by administering lethal doses of diamorphine, typically between 30 and 60 milligrams, far exceeding any legitimate therapeutic dose. The injection would cause unconsciousness within seconds and death within minutes from respiratory failure. Most victims likely never knew what was happening. Perhaps most chilling was the inquiry's finding that Shipman's killing accelerated over time. He began slowly in the 1970s, killing perhaps once or twice a year. By the 1990s, especially after opening his solo practice, he was killing 2 or 3 times per month. In some periods, he killed several patients in a single week. The acceleration suggested addiction. Like many serial killers, Shipman seemed to need more frequent kills to achieve the same psychological satisfaction. The power of ending lives, once a rare and thrilling act, became routine and required more repetition to feed his compulsion. The second report, published in July 2003, examined the police investigations of Shipman. Both the 1998 investigation triggered by Dr. Linda Reynolds and the investigation following Kathleen Grundy's death. The findings were deeply critical of the first investigation and identified systemic failures that allowed Shipman to continue killing for months after he should have been stopped. The 1998 investigation, led by Detective Inspector David Smith, had failed to uncover Shipman's crimes despite credible suspicions from a fellow physician. The inquiry identified multiple failures. The investigation relied too heavily on Shipman's own explanations and medical records, without independent verification. No statistical analysis was conducted to determine whether Shipman's death rate was actually abnormal. No effort was made to interview families of deceased patients about the circumstances of death. The investigation accepted medical examiner opinions that were based solely on Shipman's own documentation. Once Shipman provided explanations, investigators moved to close the case rather than pursuing deeper inquiry. Dame Janet concluded, "The investigation was inadequate. A more thorough inquiry would have identified suspicious patterns that should have led to further investigation and possibly to Shipman's arrest months before Kathleen Grundy's death." The inquiry estimated that the failed 1998 investigation had cost approximately 3 lives, patients who were murdered between April and September 1998, who might have been saved if Shipman had been arrested earlier. This finding was particularly painful for families of those victims. The second report also examined the successful investigation following Kathleen Grundy's death. Here, The inquiry was generally complimentary. Detective Inspector Stan Edgerton and his team had pursued the evidence methodically, expanded the inquiry when patterns emerged, and built a solid case for prosecution. But the report noted that even this successful investigation had relied heavily on Angela Woodruff's determination. Without her refusal to accept the official explanation, Shipman might still have escaped justice. The third report, published in July 2003, examined death certification and cremation procedures. This report identified the systemic weaknesses that had allowed Shipman to certify hundreds of murders as natural deaths without triggering investigation. The core problem was that the death certification system relied entirely on the honesty and competence of certifying physicians. There was no independent oversight, no requirement for a second medical opinion for most deaths, and no systematic review of death certificates to identify unusual patterns. Shipman, as the attending physician, could certify any death as natural causes by listing a plausible medical condition: heart attack, stroke, old age. Because his patients were elderly and often had some underlying health issues, his certifications appeared superficially reasonable. The system had no mechanism to detect that his death rate was far higher than normal or that his certifications were fraudulent. Cremation procedures provided slightly more oversight, requiring a second doctor to examine the body and confirm the cause of death. But in practice, this second examination was often cursory. The confirming doctor rarely challenged the certifying physician's opinion and never conducted independent investigation. The system assumed doctors were honest and trusted their professional judgment. The third report made sweeping recommendations for reform, including independent review of all death certificates by medical examiners not connected to the certifying physician, statistical monitoring to identify doctors with unusual death rates, mandatory reporting of unexpected deaths for independent investigation, stricter cremation procedures with meaningful independent review, better training for death certification, and more detailed documentation requirements. Many of these recommendations were subsequently implemented in British law through the Coroners and Justice Act 2009, fundamentally changing how deaths are certified and investigated in the United Kingdom. The fourth report, published in July 2004, examined the regulation of controlled drugs. This report identified how Shipman had obtained the diamorphine he used to kill his patients and why his use of the drug had not raised suspicion. Shipman had three main sources for diamorphine: legitimate prescriptions for terminal patients, which he then diverted for murder; excess prescriptions beyond what patients needed, with the surplus kept for his use; in some cases, stockpiling from patients who had died, claiming he was disposing of their medications when actually he was keeping them. The regulatory system for controlled drugs proved inadequate to detect this diversion. Pharmacists filled Shipman's prescriptions without questioning the quantities because he explained he was treating terminal patients at home. There was no system to track whether prescribed controlled drugs were actually given to the patients for whom they were prescribed or diverted to other uses. The fourth report recommended much stricter controls on controlled drugs, including better tracking systems to monitor prescribing patterns, mandatory reporting of unusual quantities or patterns of controlled drug prescribing, independent verification that controlled drugs prescribed were actually administered to the intended patients, stricter accountability for controlled drug storage and disposal. Again, many of these recommendations led to legislative changes, including the safer management of controlled drugs regulations introduced in 2006. The fifth report, published in December 2004, examined Shipman's career in its entirety, from medical school through his arrest. It documented his 1975 conviction for drug offenses and examined whether the decision to allow him to continue practicing medicine had been appropriate. The inquiry was critical of this decision. While rehabilitation of doctors after addiction is important, the fifth report argued that someone convicted of forging prescriptions had demonstrated fundamental dishonesty that should have permanently disqualified them from practicing medicine. The decision to allow Shipman a second chance, while seemingly compassionate, had enabled decades of murder. The report also examined Shipman's personality and psychology. Based on testimony from those who knew him and evaluation by forensic psychiatrists, the inquiry concluded that Shipman was a narcissistic psychopath who viewed himself as superior to everyone around him and felt entitled to exercise power over life and death. He showed no empathy for his victims, no remorse for his crimes, and no acceptance of responsibility for the suffering he caused. Even after conviction, he maintained his innocence and blamed others: the police for fabricating evidence, the medical examiner for incompetence, the jury for being misled. The sixth and final report, published in January 2005, brought together all the inquiry's findings and made comprehensive recommendations for reform. These recommendations address death certification, controlled drug regulation, medical oversight, whistleblower protection, and cultural changes needed in medicine. Some key recommendations included: creation of an independent medical examiner system to review all deaths, mandatory reporting and investigation of unexpected deaths, statistical monitoring of all doctors' death rates to identify outliers, stricter regulation and tracking of controlled drugs, better protection for doctors who raise concerns about colleagues, fundamental cultural change in medicine to reduce deference to physician authority and increase accountability. The Shipman inquiry's work was monumental in scope and impact. It provided definitive answers to families who had waited years to know if their loved ones were murdered. It exposed systemic failures across medicine, law enforcement, and regulation, and it produced recommendations that led to significant legal and procedural reforms. But perhaps the inquiry's most important contribution was its insistence on naming and honoring the victims. Each of the 215 confirmed victims was named in the reports. Their lives were documented, their families' testimonies recorded. They were restored from statistics to human beings who had been loved, who had mattered, whose murders demanded accountability. Dame Janet Smith concluded the inquiry's work with words that captured both the horror of Shipman's crimes and the determination to prevent future tragedies. Harold Shipman betrayed his patients' trust in the most fundamental way. The systems that should have protected them failed. We cannot bring back those who were lost, but we can honor them by ensuring that what happened to them can never happen again. Part 11. VICTMS RMMBRED. The Shipman inquiry identified 215 confirmed victims of Harold Shipman's murders, with another 45 cases deemed probable or possible but unproven. Each victim was a person with a life story, with family and friends who loved them, with years ahead that were stolen by a trusted doctor. This section honors their memory by telling some of their stories. Kathleen Grundy, 81, was the victim whose death finally exposed Shipman. A former mayoress of Hyde, she was known for her community service and her sharp mind. She had worked for years with Age Concern and other charitable organizations. Her daughter Angela described her as incredibly independent, fiercely intelligent, and full of plans. Kathleen should have had years left to volunteer, to spend time with family, to enjoy the retirement she had earned. Instead, Harold Shipman murdered her on June 24, 1998, forged her will to steal her estate, and certified her death as old age. Angela's determination to pursue the truth about her mother's death saved countless lives by ending Shipman's killing spree. Winifred Meller, 73, was a widow living in Coronation Street, Hyde. She was described by her family as the heart of our family gatherings. She loved baking and would spend hours making cakes and biscuits for her grandchildren. On May 11, 1998, she called Dr. Shipman complaining of feeling unwell. He visited her at home. When her daughter stopped by an hour later to check on her, Winifred was dead. Shipman claimed heart disease. The truth was morphine poisoning. Winifred's grandchildren testified at trial about how their grandmother had planned to attend a birthday party that weekend. She never made it. Bianca Pomfret, 49, was one of Shipman's youngest victims. A devoted mother and wife, she was active in her children's school and worked part-time at a local shop. She was looking forward to becoming a grandmother. On December 10, 1997, she complained of chest pain. Shipman visited her at home while her husband was walking the dog. 15 minutes later, she was dead. Her husband found her on the sofa with Shipman standing over her, claiming she had suffered a massive heart attack. Her children grew up without their mother because Harold Shipman decided her life was his to take. Joan Melia, 73, was known in her neighborhood for her kindness to everyone she met. She would bake cookies for the postal worker, chat with neighbors over the fence, and always had a kind word for passers-by. She was in good health and walked to the shops every day. On June 12, 1998, Shipman visited her for what he said was a routine checkup. She died within minutes of his injection. Her neighbors testified that Joan had told them just days before that she felt better than she had in years. Harold Shipman stole the rest of those years. Marie West, 81, was a widow who had raised 3 children and had 7 grandchildren and 4 great-grandchildren. She was fiercely independent despite her age, insisting on living alone and managing her own affairs. She tended a small garden and was known for growing the best tomatoes in her neighborhood. On March 6, 1995, she called Dr. Shipman about minor breathlessness. He visited her at home. Her daughter arrived an hour later to find Marie dead in her armchair. Shipman claimed coronary thrombosis. Marie's heart had been healthy. What killed her was morphine administered by the doctor she trusted. Lizzie Adams, 77, was a great-grandmother who was the memory keeper of her large extended family. She could recite every birthday, every anniversary, every important date in dozens of lives. Her family called her the family tree because she knew everyone's place and everyone's story. She was in generally good health aside from arthritis. On February 28, 1997, Shipman visited her for what he said was a routine visit. When her daughter arrived shortly after, Lizzie was dead. Her family testified that Lizzie had planned to attend a family reunion the following month. 63 family members gathered for that reunion, but Lizzie wasn't there because Harold Shipman had murdered her. Ivy Lomas, 63, died at Shipman's surgery on May 29, 1997, the only victim to die in his office rather than at home. She had arrived for a routine appointment and was asked to wait in a private examination room. When Shipman's receptionist checked on her after the appointment ran long, she found Ivy slumped in the chair, dead. Shipman claimed she had suffered heart failure while waiting. The truth was that he had injected her with morphine between patients. Ivy's daughter testified that her mother had been looking forward to retirement travel with her sister. Those trips never happened. Maureen Ward, 57, had multiple sclerosis but remained active and engaged with life. She refused to let her disability define her. She was a devoted mother and grandmother who regularly attended her grandchildren's school events despite mobility challenges. On February 18, 1998, she called Shipman complaining of fatigue. He visited her at home. Within an hour, she was dead. Shipman certified complications from MS. The truth was morphine poisoning. Her family testified that Maureen had been planning her granddaughter's upcoming birthday party. She never got to see that party. Irene Turner, 67, had recently retired from working in a local shop. She was looking forward to becoming a great-grandmother for the first time. She had early-stage arthritis but was otherwise healthy. Her daughter Carolyn visited her several times a week, and they were planning a shopping trip on July 11, 1996, when Irene called Shipman about feeling unwell. He visited her at home. When Carolyn arrived for their shopping trip, her mother was dead. Shipman claimed brain hemorrhage. Carolyn's baby, Irene's great-grandchild, was born 2 months later. Irene never got to meet her. Pamela Hillier, 68, was the youngest victim for whom Shipman was convicted. She had recently retired from teaching and was volunteering at a literacy program. She was an avid reader who had planned to spend her retirement with books and volunteer work. On February 9, 1998, Shipman visited her at home for what he said was a routine check. She died shortly after his injection. Her fellow volunteers testified that Pamela had signed up to help with a reading program that was starting the following week. The children in that program never got to meet her because Harold Shipman murdered her first. Nora Nuttall, 65, was a grandmother who babysat regularly for her working daughter. Her grandchildren adored her and called her Nana Nora. She made the best Sunday roasts and always had sweets in her pockets for children. She was in good health and active. On January 26, 1998, Shipman visited her at home. She died shortly after. Her grandchildren testified about how Nana Nora had promised to take them to the zoo that summer. She never did because she was dead, murdered by a doctor who saw her not as a beloved grandmother, but as an opportunity to kill. Kathleen Wagstaff, 81, was known in her community for her volunteer work at the local hospital. She had spent decades helping others as a hospital volunteer. The irony that a woman who had devoted her life to health care was murdered by a doctor was not lost on her family. On December 9, 1997, Shipman visited her at home. She died shortly after. Hospital staff testified at the trial that Kathleen had been scheduled to volunteer the following week and had never missed a shift in 20 years. Shipman ensured she missed that one. Muriel Grimshaw, 76, was an artist who painted watercolors. She had recently had a successful showing at a local gallery and was working on pieces for another exhibition. On July 14, 1997, Shipman visited her at home. She died shortly after his injection. Gallery owners testified that Muriel had been excited about her next show and had been planning new pieces. Those paintings were never created because Harold Shipman decided her time was up. Jean Lilly, 58, was one of the younger victims. She was a wife and mother who worked as a secretary. She had recently celebrated her 35th wedding anniversary and was planning to attend her son's university graduation the following month. On April 25, 1997, she called Shipman about feeling unwell. He visited her at home. She died shortly after. Her son graduated without his mother in the audience because Harold Shipman had murdered her weeks before the ceremony. Marie Quinn, 67, was a widow who had lost her husband to cancer 2 years earlier. She was finally beginning to rebuild her life, traveling with friends and volunteering at a charity shop. On November 24, 1998, Shipman visited her at home. This was after his arrest for Kathleen Grundy's murder, but before he was charged with other killings. Marie died shortly after his visit. She was one of his last victims, killed even as the investigation was closing in. Her friends testified that Marie had talked about finally feeling ready to move forward with her life. Shipman ended that life just as it was beginning again. These 15 victims, for whose murders Harold Shipman was convicted and tried, represent only a small fraction of the 215 confirmed deaths. Each of the other 200 victims has a similar story, a life full of meaning, plans for the future, family who loved them, years ahead that were stolen. Eva Leon, 70, was murdered on March 17, 1975, one of Shipman's earliest victims during his time in Todmorden. She was a mother and grandmother looking forward to her first great-grandchild. She died before meeting that baby. Mary Walls, 78, was murdered on November 13, 1996. She was known for her volunteer work at her church and her beautiful garden. The church community mourned someone they thought had died naturally, not knowing for years that she had been murdered. Laura Kathleen Wagstaff, 81, was murdered on December 9, 1997. She had volunteered at the hospital for decades, helping patients as a greeter and guide. The irony of being murdered by a medical professional was profound. Elizabeth Baddeley, 83, was murdered on November 20, 1997. She was a widow who had been married for 56 years. She spent her final years visiting her husband's grave every week, maintaining the site with flowers. After her murder, no one tended that grave for months until her family discovered she had been killed. Renate Overton, 47, was murdered on December 21, 1993. She was one of the youngest victims, a mother in her 40s who should have had decades of life ahead. Her children grew up without her because Harold Shipman decided to exercise his power over her life. The 215 confirmed victims ranged in age from 41 to 93. They included mothers, grandmothers, great-grandmothers, widows, retirees, volunteers, workers, artists, caregivers. They were people with rich lives, with plans, with families who loved them, and Harold Shipman murdered them all. What united them was not weakness or terminal illness. Most were in stable or good health for their age. What united them was vulnerability. They were often alone, they trusted their doctor, they were at an age where sudden death might seem plausible. Harold Shipman exploited that vulnerability systematically for more than 2 decades. The families of these 215 victims attended the Shipman inquiry, gave testimony, sought answers about how their loved ones had died and why no one had stopped the killer sooner. Their grief was compounded by betrayal, not just Shipman's betrayal but the systemic failures that had allowed him to continue killing. Many families spoke of their anger that warning signs had been missed, that investigations had failed, that their loved ones might have been saved if someone had acted sooner. But they also spoke of the importance of the inquiry's work in naming and honoring the victims, in ensuring they were not forgotten or reduced to statistics. Dame Janet Smith concluded the first report of the Shipman inquiry with these words: "Each of these 215 people was someone's mother, grandmother, wife, friend. Each had value. Each deserved to live out their natural lifespan. Harold Shipman took that from them. We honor their memory by ensuring the truth is known and by working to prevent such tragedies in the future." These victims deserve to be remembered not just as Shipman's victims, but as people who lived, who mattered, who were loved. Their names, their stories, their stolen years stand as testimony to the horror of what Harold Shipman did, and as a memorial to ensure they are never forgotten. Part 12. Final Aria Felicitiones. Harold Frederick Shipman died by suicide in his cell at Wakefield Prison on January 13, 2004, one day before his 58th birthday. He was found hanging in the early morning hours, having used bed sheets to fashion a noose. He left no note, no confession, no explanation. Even in death, he gave his victims' families no closure, no admission of guilt, no expression of remorse. His suicide came 4 years after his conviction and 3 years into his life sentence. It denied his victims' families the satisfaction of seeing him serve out his natural life in prison as the judge had intended. It also denied them any possibility that he might someday provide truthful answers about his crimes, how many he had really killed, why he had done it, what had driven him to betray his oath and his patients so completely. The timing of Shipman's suicide, just before his 58th birthday, has led to speculation that it was a final act of control. Some have suggested he chose to die on his own terms rather than grow old and infirm in prison. Others have noted that dying at age 57 allowed his wife Primrose to collect his NHS pension. Had he lived past 60, the pension would have been reduced due to his criminal conviction. Even in death, Shipman may have been manipulating the system for financial gain. Whatever his motivation, Shipman took with him the definitive answers to many questions. He never confessed to any murders. He never explained his methodology or his victim selection. He never provided insight into his psychological state or his motivations. To the end, he maintained his innocence, insisting he had been wrongly convicted. The legacy of Harold Shipman extends far beyond the 215 confirmed murders. His crimes fundamentally changed British medicine, death certification procedures, controlled drug regulation, and public trust in physicians. The Shipman Inquiry's recommendations led to sweeping reforms across healthcare and law enforcement. The introduction of medical examiners to independently review all death certificates addressed one of the key failures that had allowed Shipman to operate undetected. No longer could a single physician certify death without oversight. The system now requires independent review, particularly for unexpected deaths of patients not receiving end-of-life care. Controlled drug regulations were significantly strengthened. Prescription tracking systems now monitor patterns of controlled drug prescribing to identify outliers. Pharmacists are required to report unusual quantities or patterns. The accountability for controlled drugs from prescription through administration or disposal is much stricter than in Shipman's era. The General Medical Council reformed its approach to doctors convicted of criminal offenses. The lenient decision to allow Shipman to continue practicing after his 1975 drug conviction is now unthinkable. Current regulations impose much stricter sanctions for dishonest conduct, recognizing that integrity is fundamental to medical practice. Perhaps most importantly, the Shipman case challenged the culture of deference to medical authority that had allowed him to kill for so long. The reforms emphasized that doctors are not above scrutiny, that medical judgment should be subject to independent review, and that systems must be designed to catch the rare, malevolent physician before they can cause catastrophic harm. But beyond procedural reforms, the Shipman case raises profound questions about the nature of evil, the limits of trust, and the capacity for betrayal. Harold Shipman was not an obviously monstrous figure. He was not visibly deranged or violent. He was a family man, a respected professional, someone who appeared dedicated to his patients' welfare. The disconnect between his public persona and his secret crimes challenges our assumptions about how evil manifests. Psychological analysis of Shipman suggests he was a narcissistic psychopath, someone who viewed himself as inherently superior to others and who lacked empathy or remorse. His patients were not people to him, but objects over which he could exercise ultimate power. The act of killing brought him a sense of godlike control that nothing else in his life provided. But this psychological profile, while helpful for understanding, does not fully explain the magnitude of his crimes. Many people have narcissistic or psychopathic traits. Most do not become serial killers. What combination of personality disorder, opportunity, and psychological need drove Shipman to kill on such a scale remains partially mysterious. Some have suggested his mother's death from cancer, and his exposure to morphine's power during her final illness created a psychological template that he compulsively repeated throughout his killing career. Others point to his drug addiction and the need for control it represented. Still others focus on his sense of superiority and need to demonstrate his godlike power over life and death. The truth likely involves all these factors and more. Shipman was a complex human being whose capacity for evil was matched only by his ability to conceal it. He lived a double life for more than 2 decades, devoted doctor by day, calculating killer by afternoon, ordinary family man by evening. The compartmentalization required to sustain this double life speaks to profound psychological abnormality. The question of whether anyone suspected or knew what Shipman was doing haunted the investigation and the inquiry. His wife Primrose maintained she knew nothing of her husband's crimes and believed in his innocence even after conviction. Whether this was genuine or willful blindness remains debated. Some colleagues had noticed unusual patterns but failed to pursue their concerns. Dr. Linda Reynolds suspected something was wrong and reported it, but the investigation failed to uncover the truth. Funeral directors, taxi drivers, and others had fleeting suspicions, but dismissed them as impossible. Surely a doctor would not murder his patients. This collective failure to imagine the truth is understandable but tragic. We trust doctors with our lives. The idea that a physician would betray that trust so completely challenges fundamental assumptions about professional ethics and human decency. It was easier to explain away suspicious patterns than to contemplate that a respected GP was a mass murderer. The victims' families faced their own struggles with trust and betrayal. Many had thanked Dr. Shipman for his care of their loved ones, never knowing he had murdered them. The psychological trauma of discovering that the sympathetic doctor who had comforted them in grief was actually their loved one's killer added another layer of pain to their loss. Some families expressed feeling foolish for having trusted Shipman, though of course they had done nothing wrong. They had reasonably relied on a doctor's expertise and professional ethics. The betrayal was entirely Shipman's, but many families struggled with feelings of guilt that they had not somehow known or suspected. The Shipman case also raises questions about the limits of prevention. Even with all the reforms implemented after the inquiry, could a determined, intelligent killer with medical credentials evade detection if they chose to kill? The systems are better now. Oversight is stronger. Death certification is more rigorous. Controlled drugs are more carefully tracked. But no system is perfect, and a sufficiently cunning killer might still find ways to exploit whatever gaps remain. This sobering reality means that beyond procedural safeguards, we must cultivate a culture of appropriate skepticism and willingness to question authority when something seems wrong. Dr. Reynolds was brave to report her concerns, and the failure of the 1998 investigation should not discourage others from speaking up when patterns seem suspicious. Healthcare systems must balance trust in physicians with accountability. We cannot function if we suspect every doctor of being a potential killer, but neither can we allow professional courtesy and deference to authority to prevent investigation of genuine concerns. Finding that balance remains an ongoing challenge. The families of Shipman's victims have become advocates for patient safety and medical accountability. Many testified at the inquiry, not just to seek justice for their loved ones, but to ensure reforms would prevent future tragedies. Their courage in facing the truth about how their loved ones died, and their determination to create positive change from that horror, stands as their own memorial to those who were lost. Some have created charitable foundations in their loved ones' names, supporting medical research or patient advocacy. Others have worked with healthcare organizations to improve patient safety protocols. All have insisted that the victims be remembered as people who lived and mattered, not just as statistics in a serial killer's toll. The Shipman case remains relevant today as a reminder of several enduring truths. Trust must be balanced with accountability. Professional authority is not absolute. Systems must be designed to detect malevolent actors. Warning signs must be investigated thoroughly. And individuals who notice patterns that seem wrong have a moral obligation to speak up, even when doing so is difficult or professionally risky. Harold Shipman was an aberration, a monster hiding behind a professional facade. But the systemic failures that enabled him were not aberrations. They were the result of well-intentioned but flawed policies, cultural assumptions that prioritized professional courtesy over patient safety, and systems that failed to imagine that a trusted doctor could become a killer. The reforms implemented after the Shipman inquiry represent progress, but they are not guarantees. Vigilance must be constant. Systems must evolve as new threats emerge, and we must never become so trusting that we ignore evidence of wrongdoing simply because it seems impossible. In the end, Harold Shipman's legacy is complex. He was a mass murderer who killed at least 215 people and possibly as many as 260. He betrayed the trust of his patients, their families, and his profession. He caused immeasurable suffering and grief. But his exposure and conviction also led to reforms that have made British healthcare safer. The victims' families have ensured that their loved ones are remembered and that their deaths led to positive change. And the case serves as a permanent reminder of the importance of accountability, oversight, and the courage to question authority when something seems wrong. Harold Shipman is gone by his own hand, without ever admitting to his crimes or explaining his motivations. But the 215 victims he murdered are remembered. Their names are recorded. Their lives are honored. And the systems that failed them have been reformed to better protect future patients. This is not redemption. There is no redemption for murder on such a scale. But it is meaning drawn from horror, justice achieved despite Shipman's suicide, and determination that while we cannot bring back those who were lost, we can honor them by ensuring their deaths were not in vain. The Doctor Who Killed has become a case study in evil, a cautionary tale